Cardiovascular examination overview. A. Characteristic symptoms and pathophysiology. Dyspnea, chest pain, palpitations indicate potential cardiac distress or overload. Syncope, hemoptysis, could suggest underlying cardiovascular pathology such as arrhythmias or pulmonary hypertension. Edema, fatigue, claudication, often associated with heart failure, peripheral artery disease, or venous insufficiency. B. Clinical presentation and diagnosis, appearance observations. Signs like erythema marginatum and subcutaneous nodules suggest systemic conditions like rheumatic fever. Skin and mucous membrane changes, such as pallor, anemia, acute hemorrhage, plethora, polycythemia vera, xanthomas, hyperlipidemia. Vital signs assessment includes examining blood pressure and interpreting variations like bradycardia or tachycardia. Jugular venous pressure, JVP. Elevated JVP indicates right heart failure, constrictive pericarditis. Key waveforms include absent A wave in atrial fibrillation and prominent V wave in tricuspid regurgitation. Palpation and auscultation, essential for assessing conditions like aortic stenosis or hypertrophic cardiomyopathy. Signs include palpable pulses and heart murmurs. C. Treatment, pharmacological management, involves using medications such as beta blockers, ACE inhibitors, or diuretics, depending on the specific heart condition. Surgical interventions may include valve replacements or repair, bypass surgery based on structural abnormalities found during the exam. D. Prognosis varies, depending on the underlying cause and the effectiveness of the initiated treatment plan. Conditions like controlled hypertension have a better prognosis than complex congenital heart diseases. High yield points. Vital signs, essential for initial cardiovascular assessment. Abnormalities can guide further diagnostic testing. Heart sounds. Auscultation provides critical information about heart function and potential valvular diseases. Jugular venous pulse offers insight into right heart function and can indicate heart failure or pericardial constriction. Peripheral examination. Findings like clubbing or edema can hint at chronic cardiovascular conditions. Differential diagnosis table, condition, JVP characteristics, heart sounds, additional signs, radiates to left axilla. Aortic stenosis, normal, harsh systolic murmur at right second intercostal space, radiates to carotids. Mitral regurgitation, normal, elevated. Holosystolic murmur at apex, radiates to left axilla. Elevated S3 gallop, peripheral edema, pulmonary crackles. Pericardial effusion, elevated, distant, muffled heart sounds, pulsus paradoxus, low voltage on ECG. This table aids in distinguishing between common cardiovascular conditions based on examination findings. Each entry includes specific characteristics that help informing a differential diagnosis. Heart murmurs, auscultatory findings in different valve diseases. Heart murmurs are produced by turbulent blood flow across abnormal cardiac structures, such as valves. The following outlines key auscultatory findings associated with various valve diseases. 1. Aortic stenosis. Murmur type. Systolic ejection murmur, location, best heard at the second right intercostal space, aortic area. Radiation, radiates to the carotids. Characteristics, crescendo, decrescendo pattern, often associated with a slow rising pulse, pulsus tardus. NAR 2. Mitral regurgitation, murmur type, holosystolic and systolic murmur, location, best heard at the apex. Radiation, radiates to the left axilla. Characteristics, maintains constant intensity from S1 to S2, may be associated with a palpable thrill. 3. Aortic regurgitation, murmur type, early diastolic murmur, location, best heard at the second right intercostal space. Radiation, may not typically radiate. Decrescendo murmur, high-pitched blowing sound, often associated with bounding pulses, Corrigan pulse. Harnhar 4, mitral stenosis, murmur type, mid-diastolic murmur, location, best heard at the apex with the bell of the stethoscope. Radiation, limited radiation, low-pitched rumbling accentuated in left lateral position, may be preceded by an opening snap. 5. Tricuspid regurgitation, murmur type, holosystolic murmur, location, best heard at the lower left sternal border. Radiation, may radiate to the right of the sternum. Characteristics, intensity increases with inspiration, Carvalho's sign. HAR 6, pulmonic stenosis, murmur type, systolic ejection murmur. Location, best heard at the second left intercostal space, pulmonic area. Radiates to the left shoulder and neck. Characteristics, crescendo-decrescendo pattern, may be associated with an ejection click. High-yield auscultation tips. Positioning. Murmurs of mitral origin are best heard with the patient in the left lateral decubitus position. Respiration effects. Right-sided murmurs generally increase in intensity during inspiration. Left-sided murmurs are better heard during expiration. Use of bell versus diaphragm. The bell is superior for detecting low-pitched sounds, e.g. mitral stenosis, while the diaphragm is better for high-pitched sounds, e.g. aortic regurgitation. Each valve disease has distinctive auscultatory features that, when recognized, can lead to a quick and accurate bedside diagnosis, directing further confirmatory testing like echocardiography. Acute dyspnea, differential diagnosis. Acute dyspnea, or sudden onset shortness of breath, is a common and potentially critical symptom that can arise from a variety of conditions. A systematic approach is essential for differentiating between the possible causes. Cardiovascular causes: acute coronary syndrome, ACS, chest pain, radiating pain, diaphoresis, nausea, heart failure, orthopnea, paroxysmal nocturnal dyspnea, elevated jugular venous pressure, pulmonary crackles, peripheral edema. Pulmonary embolism, PE, pleuritic chest pain, tachypnea, hemoptysis. Risk factors include recent surgery, immobility, or active cancer. Cardiac tamponade, Beck's triad, distant heart sounds, distended jugular veins, hypotension, pulsus paradoxus. Pulmonary causes: asthma attack, wheezing cough, history of asthma, chest tightness, chronic obstructive pulmonary disease, COP exacerbation, chronic cough, sputum production, history of smoking or COPD. Pneumothorax, sudden chest pain, decreased breath sounds on affected side, hyperresonance on percussion. Pneumonia, fever, cough with sputum production, pleuritic chest pain, focal crackles. Acute respiratory distress syndrome, ARDS, severe hypoxia, recent history of a precipitating event, sepsis, trauma, pneumonia. Metabolic and systemic causes, metabolic acidosis, Kussmaul breathing, deep rapid breathing, history of diabetes, diabetic ketoacidosis, renal failure, anemia, pallor, fatigue, tachycardia, history of bleeding or chronic disease, sepsis, altered mental status, hypotension, fever or hypothermia, signs of infection. Psychological causes, anxiety or panic disorders. Episodic, may be associated with stress or emotional triggers, hyperventilation, tingling in extremities. High-yield diagnostic approaches, physical examination. Vital for assessing respiratory rate, oxygen saturation, auscultation of the lungs and heart. ECG and cardiac enzymes, essential for ruling out acute coronary syndrome. Chest X-ray helps in diagnosing pneumonia, pneumothorax, or other structural abnormalities. D-dimer, CT, pulmonary angiography, used to assess the likelihood of pulmonary embolism. Echocardiography, useful in suspected cases of heart failure or cardiac tamponade. Differential diagnosis table, condition, key features, diagnostic tests, and claim. Acute coronary syndrome, chest pain, nausea, diaphoresis, ECG, cardiac enzymes, heart failure, crackles, edema, elevated JVP, echocardiogram, BNP test. Pulmonary embolism, risk factors, hemoptysis, pleuritic pain, D-dimer, CT angiography, asthma, COPD, wheezing, history of respiratory disease, spirometry, pneumothorax, sudden onset, decreased breath sounds, chest X-ray, pneumonia, fever, productive cough, focal crackles, chest X-ray, sputum culture, metabolic acidosis, deep rapid breathing, history of diabetes, arterial blood gas, anxiety, panic disorders, stress, tingling, hyperventilation. Clinical diagnosis, understanding the specific features and diagnostic tests for each potential cause of acute dyspnea can guide appropriate management and improve patient outcomes. Acute respiratory distress syndrome, ARDS. A. Characteristic symptoms and pathophysiology. Initial presentation, rapid onset of dyspnea, cyanosis, and tachypnea. Underlying mechanism, intense inflammatory response in the lungs triggered by various systemic or pulmonary insults, leading to widespread capillary leak and alveolar damage. Pathophysiological process involves the exudative phase with pulmonary edema, formation of hyaline membranes, and decreased lung compliance, followed by potential progression to the fibroproliferative phase, leading to pulmonary fibrosis. B. Clinical presentation and diagnosis. Clinical features, acute dyspnea, tachypnea, cyanosis, and diffuse crackles. Fever, cough, and chest pain may also be present. Berlin criteria for diagnosis. Timing, acute onset within 1 week of a known clinical insult or new worsening respiratory symptoms. Radiological findings, bilateral opacities on imaging not explained by effusions, lobar lung collapse, or nodules. Oxygenation impairment, PaO2, FiO2 ratio 300 mm Herdring on the 5 cm H2O PEEP. Exclusion of cardiac failure, no evidence of heart failure or fluid overload as the cause. Treatment, General approach focuses on oxygenation and lung protective ventilation strategies. Oxygen therapy to manage hypoxemia. Mechanical ventilation, low tidal volumes, 6 to 8 milliliters per kilogram predicted body weight, and appropriate PEEP settings to minimize ventilator-induced lung injury. Prone positioning, recommended for severe cases to improve oxygenation. Additional therapies, consideration of ECMO in refractory cases and addressing any underlying causes. D. Prognosis, outcomes, variable, can range from significant improvement within weeks to progression to chronic pulmonary fibrosis. Mortality rate remains high, especially in cases complicated by multi-organ failure. ARDS is a life-threatening form of respiratory failure characterized by severe hypoxemia and bilateral lung infiltrates. Key management strategies include maintaining oxygenation and applying lung protective mechanical ventilation. The diagnosis is clinical, supported by imaging and exclusion of cardiac causes of similar symptoms. Differential diagnosis table, condition, key features, diagnostic clues. Cardiogenic pulmonary edema, history of heart disease, elevated BNP, echocardiogram, absence of infection, acute exacerbation of COPD, chronic respiratory symptoms, history of smoking, spirometry, chest X-ray, pulmonary embolism, sudden onset dyspnea, risk factors for thrombosis, D-dimer, CT, pulmonary angiography, pneumonia, fever, localized symptoms, productive cough, chest X-ray, sputum culture, transfusion-related injury, TACO, recent transfusion, onset during, shortly after transfusion, clinical history, exclusion of other causes. These considerations ensure a comprehensive approach to the diagnosis and management of ARDS, optimizing patient care and addressing the complexity of this critical condition. Acute asthma exacerbation overview. A. Characteristic symptoms and pathophysiology. Bronchospasm, sudden constriction of the muscles in the airway walls, leading to narrowing and obstruction. Inflammatory response, triggered by various stimuli, causing increased mucus production and further airway narrowing. Reversibility, a hallmark of asthma, where bronchodilation can be achieved with appropriate treatment. B. Clinical presentation and diagnosis. Symptoms: dyspnea, increased coughing, wheezing, and use of accessory muscles for breathing. Signs of severe exacerbation: silent chest, paradoxical breathing, altered mental status, and cyanosis. Diagnostic tools: peak flow meter, PFM, measures peak expiratory flow, PEF, providing quantitative data on airflow obstruction. Spirometry assesses lung function but may not be feasible during severe exacerbations. Arterial blood gas, used to evaluate gas exchange efficiency, particularly in severe cases showing respiratory alkalosis initially and potentially progressing to respiratory acidosis. Chest X-ray, generally used to exclude other causes of symptoms like pneumonia or pneumothorax rather than for direct diagnosis of asthma. C. Treatment: initial management, immediate administration of high-flow oxygen and fast-acting bronchodilators, SABAs, possibly SAMAs, and systemic glucocorticoids. Severe cases may require intravenous magnesium sulfate, continuous nebulized SABA, or intubation and mechanical ventilation if there is evidence of impending or actual respiratory arrest. Monitoring and adjustments. Continuous monitoring of respiratory status and adjustment of therapy based on response. Deprognosis. Immediate response, generally good with rapid and appropriate treatment. Long-term management requires adjustment of asthma maintenance therapy to prevent further exacerbations. High yield points, SABA, albuterol, primary treatment for reversing airway constriction. Systemic corticosteroids, essential for reducing airway inflammation. Oxygen therapy, critical for managing hypoxemia. Monitoring, peak expiratory flow and ABG are valuable for assessing severity and progression. Differential diagnosis table. Condition key features, diagnostic approach, spirometry, chest x-ray, acute bronchitis, cough, slight dyspnea without severe wheezing, clinical evaluation, chest x-ray, COPD exacerbation, history of smoking, chronic productive cough, spirometry, chest x-ray, pulmonary embolism, sudden onset, risk factors for thrombosis, D-dimer, CT pulmonary angiography, pneumothorax, sudden sharp pain, unilateral chest expansion, chest x-ray, pneumonia, fever, localized crackles, productive cough, chest x-ray, sputum culture, acute heart failure, orthopnea, paroxysmal nocturnal dyspnea, echocardiogram, BNP. Understanding these aspects of acute asthma exacerbations allows for effective and swift treatment, which is crucial to prevent life-threatening complications and improve patient outcomes. Chest pain, differential diagnosis. Chest pain is a common and concerning symptom with a wide array of potential causes, ranging from benign to life-threatening conditions. Here's a structured approach to considering the differential diagnosis based on the characteristics and associated symptoms of the pain. A. Cardiovascular causes. Acute coronary syndrome, ACS, includes unstable angina and myocardial infarction. Typically presents as pressure or tightness in the chest, radiating to the arm, neck, or jaw, often accompanied by sweating, nausea, or shortness of breath. Aortic dissection, sudden severe tearing chest pain radiating to the back, may have differential blood pressures in arms or aortic regurgitation murmur. Pericarditis, sharp and pleuritic chest pain relieved by sitting up and leaning forward, may be associated with a pericardial rub on auscultation. Pulmonary embolism, sharp, pleuritic chest pain with dyspnea, tachypnea, and sometimes hemoptysis. Risk factors include recent surgery, immobilization, and active cancer. B. Respiratory causes. Pneumonia, chest pain that is sharp and worsens with deep breaths, often accompanied by fever, productive cough, and dyspnea. Pneumothorax, sudden onset of sharp unilateral chest pain with dyspnea. Physical exam may show decreased breath sounds and hyperresonance on the affected side. Pleuritis, sharp stabbing pain that worsens with inspiration. C. Gastrointestinal causes. Gastroesophageal reflux disease, GERD, burning pain behind the sternum, often after eating, lying down, or bending over, may be associated with regurgitation of stomach acid. Esophageal spasm, intense spasm-like pain similar to cardiac chest pain, but often related to swallowing. Peptic ulcer disease, epigastric pain that may radiate to the back, often relieved by eating or antacids. D. Musculoskeletal causes, costochondritis, pain in the costosternal or costochondral junctions that is reproducible with palpation. Rib fracture, sharp pain exacerbated by movement, breathing, or coughing, confirmed by palpation or imaging. Myofascial pain, localized muscle pain with possible palpable bands or trigger points. E. Psychological causes, anxiety and panic disorders, may present with chest pain along with palpitations, shortness of breath, and a feeling of impending doom, often occur in episodes. High-yield diagnostic approaches, ECG and cardiac enzymes, essential for ruling out ACS. Chest X-ray, useful for diagnosing pneumonia, pneumothorax, and other structural abnormalities. D-dimer and CT pulmonary angiography, used when PE is suspected. Esophageal manometry and pH monitoring, helpful for diagnosing esophageal causes of chest pain. Differential diagnosis table, condition, typical pain description, key diagnostic tools, acute coronary syndrome, pressure, radiating with exertion, ECG, troponins, aortic dissection, tearing, radiating to the back, CT angiography, echocardiogram, pulmonary embolism, sharp, pleuritic, sudden onset, CT pulmonary angiogram, D-dimer, pneumonia, sharp, worsens with breaths, chest X-ray, sputum culture, GERD, burning postprandial, endoscopy, pH monitoring, costochondritis, reproducible with palpation, physical exam, proper evaluation and management of chest pain depend on a thorough history, physical examination, and the judicious use of diagnostic testing to differentiate among these potential causes and direct appropriate treatment. Chest pain, differential diagnosis. Chest pain can stem from various systems and has multiple etiologies, ranging from non-life-threatening to emergent conditions that require immediate medical attention. Here's a comprehensive review focusing on the identification and diagnosis of common and important causes of chest pain. A. Cardiovascular causes. Acute coronary syndrome, ACS, including STEMI, NSTEMI, and unstable angina, presents as pressure-like chest pain radiating to the arm or jaw, often accompanied by diaphoresis, nausea, or shortness of breath. Aortic dissection. Severe, tearing chest pain that radiates to the back may be associated with asymmetric blood pressures and a pulse deficit. Pericarditis, sharp, pleuritic chest pain that improves with sitting up and leaning forward, may have a pericardial rub. Cardiac tamponade, characterized by hypotension, jugular venous distension, muffled heart sounds, Beck's triad, and pulsus paradoxus. B. Pulmonary causes, pulmonary embolism, PE, sudden onset of pleuritic chest pain, shortness of breath, and possibly hemoptysis. Risk factors include recent surgery or immobilization. Pneumothorax, sudden, sharp unilateral chest pain and dyspnea, decreased breath sounds and hyperresonance on the affected side. Pneumonia typically presents with fever, cough, and pleuritic chest pain, which is sharp and worsens with deep breaths. C. Gastrointestinal causes, gastroesophageal reflux disease, GERD, burning sensation behind the sternum, often worsened by lying down or eating spicy or acidic foods. Esophageal spasm, intermittent chest pain that can mimic cardiac chest pain. Peptic ulcer disease, epigastric pain that may radiate to the back, often relieved by eating or antacids. D. Musculoskeletal causes, costochondritis, pain at the costosternal junctions that is reproducible with palpation. Tietze syndrome, similar to costochondritis, but with noticeable swelling at the costal cartilages. E. Psychiatric causes, panic disorder, chest pain accompanied by palpitations, sweating, and a sense of doom. May cause chest pain or discomfort, often with hyperventilation. High-yield diagnostic approaches, ECG and cardiac biomarkers, critical for diagnosing ACS. ECG can show changes indicative of ischemia or infarction. D-dimer and imaging, CTA or VQ scan for suspected PE. D-dimer is useful for ruling out PE in low-risk patients. Chest X-ray, useful for identifying pneumothorax, pneumonia, and other chest pathologies. Echocardiography, important for diagnosing pericarditis, cardiac tamponade, and aortic dissection. Differential diagnosis table, condition, typical symptoms, diagnostic tests. Etiation to the back, acute coronary syndrome, chest pain, sweating, nausea, ECG troponins, coronary angiography, aortic dissection, tearing pain, radiation to the back, CT angiography, echocardiography, pulmonary embolism, pleuritic pain, dyspnea, D-dimer, CT pulmonary angiogram. Pneumothorax, sudden sharp pain, dyspnea, chest X-ray, ultrasound. GERD, burning behind sternum, endoscopy, pH monitoring. Costochondritis, localized anterior chest pain, physical examination, exclusion of other causes. Effective management of chest pain requires a careful evaluation of history, symptoms, and rapid diagnostic testing to identify potentially life-threatening conditions quickly and accurately. This approach ensures timely and appropriate management to improve patient outcomes. Diagnostic algorithm for a patient with chest pain. A systematic approach to diagnosing chest pain helps identify the underlying cause efficiently, prioritizing conditions based on severity and the likelihood of life-threatening issues. Below is a detailed diagnostic algorithm tailored for medical professionals encountering patients with chest pain. Initial assessment. 1. Patient stabilization and triage. Assess vital signs, blood pressure, heart rate, oxygen saturation, respiratory rate. Perform ABCD assessment, airway, breathing, circulation, disability, exposure, to identify any immediate life-threatening conditions. 2. Obtain a brief history, Characterize the pain, onset, location, duration, nature, radiation, associated symptoms, dyspnea, diaphoresis, nausea. Identify risk factors, past medical history, cardiac disease, pulmonary disease, gastrointestinal issues, recent activities, and family history. 3. Physical examination. Inspect skin color, presence of sweating, palpate, chest wall for tenderness, auscultate heart and lungs. Look for signs of distress or hemodynamic instability. Immediate diagnostic testing. 1. 12-lead ECG within 10 minutes of patient's arrival to identify acute coronary syndromes, arrhythmias, or other cardiac conditions. 2. Chest X-ray to detect pneumothorax, pneumonia, or other structural abnormalities. 3. Blood tests, cardiac enzymes troponin to rule out myocardial infarction. Complete blood count, CBC, basic metabolic panel, BMP, D-dimer, if pulmonary embolism is suspected based on risk factors and clinical presentation. Further evaluation based on initial findings. 1. High risk for ACS or cardiac causes. Use of risk stratification tools. Heart score for ACS. Further cardiac markers and repeat ECGs. Consider urgent coronary angiography if ACS is highly suspected. 2. Suspected aortic dissection, CT angiography of the chest with contrast, transthoracic echocardiography, TTE, or transesophageal echocardiography, E, if CT is unavailable. 3. Suspected pulmonary embolism, CT pulmonary angiography, gold standard for diagnosis. VQ scan if CT is contraindicated. 4. Suspected gastrointestinal causes, upper endoscopy if symptoms suggest GERD, peptic ulcer disease, or other GI disorders. Abdominal ultrasound if biliary or pancreatic disease is suspected. 5. If musculoskeletal pain is suspected, further evaluate with MRI or CT if no immediate cardiac or pulmonary cause is identified, especially if pain is reproducible with palpation or movement. Special considerations. Elderly patients may have atypical presentations. Women and diabetic patients may present with subtler or atypical symptoms of coronary artery disease. Continuous monitoring is recommended for all patients suspected of having a serious cause of chest pain until stable or definitive diagnosis is made. Decision-making and referral. Based on the clinical findings and initial tests, decide on immediate interventions, e.g. thrombolytics for confirmed MI. Admission versus discharge. Patients with confirmed serious conditions, e.g. ACS PE, should be admitted. Patients in whom serious conditions have been ruled out and who have stable vitals may be considered for discharge with outpatient follow-up. Follow-up. Ensure that all patients have clear instructions for follow-up, especially if discharged from the emergency setting. Schedule follow-up appointments and provide guidelines on when to return to the ER if symptoms recur or worsen. This algorithm serves as a framework, and clinical judgment should always be applied based on individual patient circumstances and responses during the evaluation process. Acute coronary syndrome, ACS, diagnostic and management algorithm, initial assessment and stabilization, one patient presentation, symptoms, typically includes chest pain, pressure, tightness, which may radiate to the arm, neck, or jaw. Dyspnea, nausea, and diaphoresis are common. Physical examination. Check for signs of distress, pallor, sweating, vital sign abnormalities, e.g., tachycardia, hypotension. 2. Immediate actions, ABCDE assessment. Prioritize airway, breathing, circulation, disability, and exposure to evaluate and stabilize the patient. Vital signs monitoring, including continuous ECG monitoring. Oxygen therapy. Administer if SpO2 90% or if there are signs of respiratory distress. Diagnostic evaluation. 1. 12-lead ECG. Timing. Obtain within 10 minutes of patient's arrival. Findings. Look for ST segment elevations, new onset left bundle branch block, ST depressions, and T-wave inversions. 2. Cardiac biomarkers, troponins. Draw at presentation and repeat based on timing of onset and initial results. Typically 3 to 6 hours after the first sample if initial is negative, but suspicion remains high. Other markers, myoglobin, CKMB might be used additionally but are less specific and sensitive compared to troponins. The risk stratification, heart score, for emergency department risk stratification of chest pain. TIMI score, for NSTE-ACS to predict the likelihood of adverse cardiac events, GRACE score, to estimate mortality from ACS. Management based on ACS type 1, STEMI, T elevation myocardial infarction. Reperfusion therapy, immediate PCI, percutaneous coronary intervention, is preferred if within 90 minutes from first medical contact. If PCI is not available, consider fibrinolytic therapy within 30 minutes of hospital arrival. Medications, dual antiplatelet therapy, AC, aspirin and a P2Y12 inhibitor, clopidogrel, ticagrelor, or prasugrel. Anticoagulants, heparin, low molecular weight heparin, or bivalirudin. 2. NSTE-ACS, non-ST elevation acute coronary syndrome, invasive versus conservative strategy, decided based on risk stratification scores and clinical judgment. Medications, DAPT and anticoagulation as per STEMI, but tailored to risk and timing of potential procedures. Consider beta blockers, ACE inhibitors, or statins based on patient stability and absence of contraindications. Additional considerations: 1. Adjunctive therapies. Beta blockers. Early administration within 24 hours unless contraindicated, e.g. signs of heart failure, low output state, or other contraindications like asthma. High-intensity statins, initiated as soon as possible, regardless of baseline LDL levels. ACE inhibitors, for patients with LV dysfunction, hypertension, diabetes, or chronic kidney disease. 2. Monitoring and support, ECG, continuous monitoring for changes or arrhythmias. Echocardiography, useful for evaluating ventricular function complications and as a differential diagnostic tool when the diagnosis is unclear. Long-term management. 1. Lifestyle modification, smoking cessation, diet, physical activity. 2. Medication adherence, ensure understanding and compliance with medication regimens, especially DAPT. 3. Cardiac rehabilitation, recommended to improve long-term outcomes. Follow-up. 1. Routine follow-up, with primary care or a cardiologist to monitor recovery and manage risk factors. 2. Further testing. Stress testing or repeat imaging may be indicated based on recovery and symptoms. This structured approach ensures that patients with ACS are quickly identified and appropriately managed, reducing the risk of complications and improving outcomes. Edema, comprehensive overview and diagnostic approach. A. General features. Definition: edema is the accumulation of excess fluid in the interstitial spaces of tissues. Types: peripheral edema, commonly seen in the lower extremities, can be either pitting or non-pitting. Internal edema involves fluid accumulation within internal organs or body cavities, e.g., pulmonary edema ascites. B. Pathophysiology, fluid imbalance, results from an imbalance in the forces and mechanisms that regulate fluid movement across capillary walls into tissues. Mechanisms: increased hydrostatic pressure, common in conditions like heart failure, causing fluid to be pushed into the interstitial spaces. Decreased oncotic pressure, due to hypoalbuminemia, often seen in liver disease or nephrotic syndrome, leading to fluid leakage from vessels. Increased capillary permeability, typically seen in inflammation or injury. Lymphatic obstruction prevents fluid from draining out of tissues, as seen in lymphedema. See clinical presentation. Pitting edema, indentation remains when pressure is applied and released. Non-pitting edema, no indentation when pressure is applied, commonly seen in lymphedema or myxedema. Localization, localized edema, limited to specific areas, often due to local injury or inflammation. Generalized edema, anasarca, widespread swelling affecting the whole body, often seen in severe systemic diseases. D. Causes and specific types. 1. Cardiac edema, often manifests as bilateral pitting edema due to congestive heart failure. 2. Renal edema, associated with protein loss in nephrotic syndrome, leading to generalized edema, including periorbital puffiness. 3. Hepatic edema, occurs in cirrhosis with ascites and peripheral edema due to decreased protein synthesis. 4. Nutritional edema, caused by malnutrition or protein deficiency. 5. Lymphedema, non-pitting edema, often localized to limbs or genital areas due to lymphatic system blockages. E. Diagnostic evaluation, medical history, assess for underlying conditions, renal, hepatic, medication use, and dietary habits. 2. Physical examination, check for signs of fluid retention, distribution of edema, and associated symptoms. 3. Diagnostic tests, blood tests, complete blood count, renal function tests, liver function tests, serum albumin. Urinalysis, to check for proteinuria. Imaging, echocardiography for cardiac assessment, duplex ultrasonography for venous thrombosis, and possibly CT or MRI if lymphedema is suspected. Cardiac testing, ECG and chest X-ray to evaluate heart size and pulmonary status. F. Management strategies. 1. Treat underlying cause, address the primary disease process causing the edema. 2. Lifestyle modifications, dietary sodium restriction, and weight management. 3. Medications, diuretics for fluid overload, particularly in cardiac and renal edema. Albumin replacement in cases of severe hypoalbuminemia. 4. Compression therapy, especially for venous and lymphatic edema. 5. Physical therapy, including exercises to improve lymphatic drainage. G. Prognosis, dependent on the underlying cause. Chronic management may be necessary for conditions like heart failure and chronic kidney disease. This structured approach ensures a thorough evaluation of edema, aiding in pinpointing the underlying cause and directing appropriate treatment to manage the symptoms and address the root of the problem effectively. Diagnostics of peripheral edemas. Peripheral edema is the swelling of tissues in the lower limbs, which can be a sign of various underlying conditions. Proper diagnostic evaluation is crucial to identify the specific cause and guide effective management. Here's a step-by-step approach to the diagnostics of peripheral edema. Initial clinical assessment. 1. Medical history, duration, and progression of edema. Associated symptoms such as pain, redness, or systemic symptoms like dyspnea or fatigue. Past medical history, including heart, liver, kidney diseases, and previous episodes of edema. Medication review. Some medications, such as calcium channel blockers, can cause peripheral edema. Dietary habits, intake of salt and fluid. Family history, especially of cardiac, renal, or venous diseases. 2. Physical examination, inspection. Note the distribution and extent of edema. Bilateral edema often suggests systemic causes, while unilateral edema suggests local issues like venous thrombosis. To determine if the edema is pitting or non-pitting. Pitting edema leaves a dent when pressed, which is common in conditions with fluid overload. Assessment of associated signs, such as skin changes, ulceration, temperature differences between limbs, and signs of venous insufficiency like varicose veins. Diagnostic testing 1. Complete blood count, CBC, to check for anemia or signs of infection. Renal function tests, blood urea nitrogen, creatinine, to assess kidney function. Liver function tests, albumin, bilirubin, liver enzymes. Low albumin can cause edema. Urinalysis. Proteinuria may indicate nephrotic syndrome. Thyroid function tests. Hypothyroidism can cause non-pitting edema. Electrolytes, to look for electrolyte imbalances. Cardiac enzymes, if cardiac cause is suspected. 2 imaging studies, Doppler ultrasound, first-line imaging for suspected venous thrombosis. Echocardiography, to assess cardiac function if heart failure or other cardiac sources of edema are suspected. Chest X-ray, if pulmonary conditions or cardiac issues are considered. CT or MRI, useful if the cause remains unclear or to evaluate for possible tumors or other obstructions affecting lymphatic or venous outflow. 3. Specialized tests. Venography, occasionally used if Doppler ultrasound is inconclusive but deep vein thrombosis is still suspected. Lymphoscintigraphy, for evaluating suspected lymphedema. Follow-up and referral. Referral to specialists may be necessary based on initial findings such as a cardiologist for heart failure, a nephrologist for kidney-related causes, or a vascular surgeon for severe venous or lymphatic disorders. Monitoring. Patients with chronic conditions causing edema, such as heart failure or chronic venous insufficiency, need regular follow-up to manage the underlying condition and adjust treatments. Conclusion. The approach to diagnosing peripheral edema involves a thorough clinical evaluation followed by targeted diagnostic tests to confirm the underlying cause. Early and accurate diagnosis is crucial for managing the edema effectively and preventing complications related to the underlying disease. Pulmonary examination, a comprehensive guide. A. Overview. Pulmonary examination is an essential component of a physical exam, especially in patients presenting with respiratory symptoms. The exam consists of 4 main steps: inspection, palpation, percussion, and auscultation. Each step provides valuable insights into the functioning and structure of the respiratory system. B. Inspection. 1. Observations, breathing pattern and rate. Note any deviations from normal respiratory rates, 12 to 20 breaths per minute in adults. Effort of breathing. Assess for any use of accessory muscles, which may indicate increased work of breathing. Symmetry. Look for symmetrical chest movement. Asymmetry may suggest underlying pathology. Cyanosis or pallor. These can be signs of poor oxygenation. Abnormalities in chest shape, such as barrel chest in COPD or kyphoscoliosis impacting breathing. 2. Abnormal respiratory patterns, Cheyne-Stokes respiration, alternating periods of deep breathing and apnea, commonly seen in heart failure or central nervous system disorders. Kussmaul breathing, deep and labored breathing pattern often associated with metabolic acidosis. Obstructive breathing, prolonged expiration suggesting airway obstruction. C. Palpation. 1. Chest wall movement. Place hands symmetrically on the posterior chest wall to feel for equal expansion. 2. Tactile fremitus. Have the patient say 99 while palpating the chest wall with the hands. Increased fremitus may suggest consolidation, e.g. pneumonia, while decreased may indicate a pleural effusion or pneumothorax. D. Percussion. 1. Technique. Tap on the chest wall using the middle finger of one hand laid flat on the chest, striking with the middle finger of the other hand. 2. Findings. Resonant sound, normal finding over healthy lung tissue. Dullness suggests consolidation, fluid, or mass under the area being percussed. Hyperresonance may indicate the presence of air, e.g. pneumothorax or emphysema. 1. Breath sounds. Vesicular, normal breath sounds, soft and low-pitched, heard over most of the lungs. Bronchial, louder, higher-pitched sounds heard over the trachea. Hearing these sounds over the lungs can indicate consolidation. Decreased or absent sounds can indicate air or fluid in or around the lungs. 2. Adventitious sounds, crackles, rails, faint, high-pitched sounds heard during inspiration, not cleared by a cough, e.g. pulmonary edema, fibrosis, pneumonia. Wheezes, musical sound during expiration caused by narrowed airways, e.g. asthma, COPD. Stridor, a harsh, vibratory sound due to upper airway obstruction requiring immediate attention. F. Additional tests. Tracheal deviation, assessed by palpation. Deviation can suggest significant mediastinal shift due to conditions like tension pneumothorax. Diaphragmatic excursion, evaluated during deep breathing to assess diaphragmatic movement. Limited movement may suggest paralysis or restriction. G. Diagnostic integration. Transmitted voice sounds, including bronchophony, egophony, and whispered pectoraliquy, can further help differentiate lung pathologies. For example, egophony, E to A change, is often heard over areas of pneumonia. H. Conclusion. A thorough pulmonary examination, when combined with a detailed history, can lead to the preliminary differentiation of various pulmonary conditions, guiding further diagnostic testing and management. This systematic approach is crucial for effectively addressing the vast spectrum of respiratory disorders. Hypoxia and cyanosis. Overview, pathophysiology, and clinical presentation. A. Hypoxia. Definition. Hypoxia refers to a state where there is inadequate supply at the tissue level despite adequate perfusion. It can result from several underlying mechanisms. Pathophysiology. 1. Hypoxic hypoxia. Low arterial oxygen tension, often due to respiratory issues like high altitudes, hypoventilation, or diffusion impairment. 2. Anemic hypoxia. Decreased total amount of oxygen bound to hemoglobin, as seen in anemia or carbon monoxide poisoning. 3. Circulatory hypoxia, due to reduced cardiac output or localized blood flow obstruction, limiting oxygen delivery to tissues. 4. Histotoxic hypoxia occurs when tissues are unable to use oxygen, as seen in cyanide poisoning. Clinical presentation, fatigue, breathlessness, and confusion are common symptoms. Severe cases may present with altered mental status, cyanosis, and signs of organ dysfunction, particularly in the heart and brain. B. Cyanosis. Definition. Cyanosis is a bluish or purplish discoloration of the skin and mucous membranes due to increased concentration of deoxygenated hemoglobin, greater than 5 gram per dl in the blood, which may be indicative of underlying hypoxia. Types. 1. Central cyanosis, observed in the lips, tongue, and mucous membranes, usually indicates serious systemic hypoxia and is common in cardiovascular or severe pulmonary conditions. 2. Peripheral cyanosis, seen in extremities, nail beds, and skin, often due to local vasoconstriction and sluggish blood flow, which increases oxygen extraction from blood at those sites. Pathophysiology. Central cyanosis, often caused by right to left cardiac shunts, severe pulmonary disease, or abnormal hemoglobin variants. Peripheral cyanosis, more localized issues like Raynaud's phenomenon, exposure to cold, or arterial occlusion. Clinical presentation. Central cyanosis is typically a sign of severe hypoxia and warrants immediate investigation. Peripheral cyanosis might be benign if transient and isolated, but could be significant if persistent and accompanied by other symptoms of vascular compromise or hypoxia. See diagnostic evaluation. 1. Pulse oximetry and ABG, essential for measuring the levels of oxygen saturation, SPO, and arterial oxygen content, PaO2, respectively. 2. Complete blood count to rule out anemia as a cause of anemic hypoxia. Through chest X-ray and echocardiogram to identify any cardiopulmonary pathology contributing to hypoxia. 4. Electrocardiogram to assess for signs of cardiac ischemia or arrhythmias secondary to hypoxia. D. Management. Oxygen therapy, the primary treatment for hypoxia, adjusting the mode based on the severity and cause, nasal cannula, mask, mechanical ventilation. Address underlying cause. Specific treatments depend on the identified cause, such as antibiotics for pneumonia or interventions for cardiac issues. Monitoring. Continuous observation with pulse oximetry and frequent ABG assessments to monitor response to treatment. Conclusion. Understanding the distinction between hypoxia and cyanosis, along with their underlying causes, is crucial for effective management. Immediate assessment and intervention can prevent serious complications associated with inadequate oxygenation, highlighting the importance of timely recognition in clinical practice. Hypoxia and cyanosis, comprehensive overview. A. Hypoxia, definition. Hypoxia refers to a condition where there is inadequate oxygen supply to meet the metabolic demands of tissues. Pathophysiology, hypoxic hypoxia, hypoxemic hypoxia, reduced oxygen levels in the blood, often due to respiratory disorders like COPD, pneumonia, or high altitude. Anemic hypoxia, diminished oxygen carrying capacity of the blood, as seen in anemia or carbon monoxide poisoning. Circulatory hypoxia, decreased cardiac output or blood flow issues, such as in shock or severe heart failure. Histotoxic hypoxia, the inability of cells to utilize oxygen due to toxins such as cyanide. Clinical presentation, shortness of breath, cyanosis, increased heart rate, confusion, and fatigue. Severe cases may lead to altered consciousness, severe respiratory distress, and organ failure. B. Cyanosis. Definition: cyanosis is the bluish discoloration of the skin and mucous membranes caused by an excess of deoxygenated hemoglobin in the blood. Types: central cyanosis affects the lips, tongue, and torso, reflecting systemic hypoxia. Peripheral cyanosis affects the extremities, often due to local vasoconstriction or stasis. Pathophysiology: central cyanosis is generally due to respiratory or circulatory issues that impair oxygenation. Peripheral cyanosis may be caused by reduced blood flow, cold exposure, or more benign conditions. Clinical presentation: blueness of the skin, cold extremities for peripheral cyanosis. More concerning signs like confusion or tachypnea may accompany central cyanosis. C. Diagnostics. Pulse oximetry, non-invasive method to measure oxygen saturation. Arterial blood gas provides a detailed assessment of oxygenation, carbon dioxide levels, and acid-base status. Complete blood count, CBC, can identify anemia or polycythemia. Chest X-ray or CT scan, useful in diagnosing underlying pulmonary conditions. Echocardiography assesses cardiac function when a heart-related cause is suspected. D. Treatment. Oxygen therapy. Administer oxygen to improve saturation. Adjust based on ABG results and clinical response. Treat underlying cause. Address the root cause, such as antibiotics for pneumonia, interventions for cardiac conditions, or ventilation for respiratory failure. Monitoring. Regular ABG, continuous pulse oximetry, and monitoring in an intensive care setting for severe cases. Prognosis. The prognosis of hypoxia and cyanosis depends significantly on the underlying cause, the speed of diagnosis, and the initiation of appropriate treatment. Chronic conditions may require long-term management strategies to prevent recurrent hypoxia or cyanosis. Understanding the distinction between hypoxia and cyanosis, their pathophysiological bases, and associated clinical manifestations is crucial for timely and effective treatment, which can significantly influence outcomes in affected patients. Syncope and presyncope, diagnostic approach. A definition and overview. Syncope, a sudden transient loss of consciousness with an inability to maintain postural tone, followed by spontaneous recovery. Presyncope, often referred to as near fainting, involves symptoms similar to syncope, e.g. lightheadedness, visual disturbances, without complete loss of consciousness. B. Initial evaluation. In 1. History. Timing and triggers. Identify when and how symptoms occur, and any potential triggers, e.g. standing up, emotional stress. Symptom characteristics. Determine if there was any warning, the duration of unconsciousness, and recovery period. Medical history. Review cardiac history, neurological disorders, and any medications that could contribute to syncope or presyncope. Family history. Inquire about genetic conditions that could predispose to syncope, such as inherited arrhythmias. Physical examination. Vital signs. Check for orthostatic changes in blood pressure and heart rate. Cardiovascular examination. Look for signs of heart failure, murmurs, or irregular pulse. Neurological examination. Assess for neurological deficits that might suggest a stroke or seizure. 3. ECG. An electrocardiogram is essential in all patients presenting with syncope or presyncope to rule out arrhythmic causes. C. Further diagnostic testing. 1. Laboratory tests, CBC electrolytes, glucose, and renal function tests to rule out metabolic causes. Cardiac enzymes if myocardial infarction is suspected. 2. Imaging. Echocardiography to evaluate structural heart disease. Head CT or MRI if a neurological cause is suspected based on clinical findings. 3. Specialized tests. Holter monitoring or event recorder for detecting intermittent arrhythmias not captured during a brief ECG. Tilt table test, used when vasovagal syncope is suspected but not confirmed by the initial evaluation. Electrophysiological study, considered in cases with suspected arrhythmic syncope and inconclusive non-invasive testing. D. Risk stratification. Low risk, no heart disease and benign triggers. High risk, known heart disease, abnormal ECG findings, or syncope during exertion. E. Management strategy. Immediate management. Treat any acute abnormalities found during the initial assessment. For cardiac syncope, initiate appropriate cardiology treatments, e.g. pacemaker, medication adjustments. For reflex-mediated or orthostatic syncope, implement physical counterpressure maneuvers or medication adjustments. Long-term management. Education on avoidance of triggers and situations that precipitate syncope. For recurrent cases, consider lifestyle changes, increased salt intake, or use of fludrocortisone and midodrine under supervision. Prognosis. Generally favorable for reflex and orthostatic syncope. Potentially serious or life-threatening if related to cardiac causes, necessitating thorough investigation and targeted treatment. This structured approach ensures that syncope and presyncope are comprehensively evaluated, underlying causes are accurately identified, and appropriate management strategies are implemented to prevent recurrence and improve patient outcomes. Syncope and presyncope diagnostic approach. A definition and initial assessment. Syncope, a transient loss of consciousness with rapid spontaneous recovery. Primary mechanism is cerebral hypoperfusion. Presyncope, similar symptoms to syncope but without complete loss of consciousness. B. Detailed history. Identify triggers and circumstances, such as physical activity, posture changes, or emotional stress. Symptom description. Duration, presence of prodrome, e.g. nausea, dizziness, and mode of recovery. Medical history, include cardiac, neurological, and medication history. Family history, note any history of sudden cardiac death or familial diseases. C. Physical examination. Vital signs, check blood pressure and heart rate in different positions, supine, sitting, standing. Cardiac examination, search for murmurs, irregular heart rhythms, and signs of heart failure. Neurological examination, assess for neurological deficits which might indicate a central cause of syncope. D-electrocardiogram ECG, initial ECG, check for arrhythmias, ischemic changes, or other cardiac conditions that could cause syncope. E. Additional diagnostic tests, Holter monitor or event recorder, if arrhythmias are suspected but not seen on the initial ECG. Echocardiogram, evaluate for structural heart disease. Tilt table test, used if a vasovagal or orthostatic cause is suspected. Blood tests check hemoglobin levels, electrolytes, and markers of myocardial injury. Stress testing, if syncope is exercise-induced, consider stress testing to provoke symptoms under controlled conditions. F. Further specialized testing, if indicated, implantable loop recorder, for unexplained recurrent syncope where other investigations are non-diagnostic. Autonomic function tests, if autonomic dysfunction is suspected. Neurological imaging, CT, MRI, if there are focal neurological signs or a significant head injury history. Psychiatric evaluation, if psychological factors are suspected. G. Risk stratification, low risk, no heart disease and a benign trigger identified. High risk includes known heart disease, abnormal ECG, syncope during exertion, or lack of prodromal symptoms. H. Management and follow-up. For cardiac causes, immediate intervention may be necessary, including pacemakers for bradyarrhythmias or ablation for tachyarrhythmias. For non-cardiac causes, education on trigger avoidance and lifestyle modifications, medication adjustments, or physical counter-pressure maneuvers for reflex syncope. Emergency management. If syncope is associated with severe pain, palpitations, or chest discomfort, urgent care is necessary. I. Prognosis. Generally good for non-cardiac syncope with appropriate management and prevention strategies. Potentially serious for cardiac syncope, requiring specific interventions and close monitoring. This approach ensures comprehensive evaluation and management of syncope and pre-syncope, tailored to the underlying cause and individual patient risk factors. Palpitations, management overview. Palpitations are sensations of having a rapid, fluttering, or pounding heartbeat. Management of palpitations depends primarily on determining the underlying cause, which can range from benign to life-threatening cardiac conditions. A. Initial assessment and history. 1. Symptom description, frequency, duration, and triggers. Associated symptoms such as dizziness, syncope, chest pain, or shortness of breath. 2. Medical and family history. Any known heart conditions, previous cardiac evaluations or surgeries. Family history of cardiac disease or sudden death. B. Physical examination. 1. Vital signs. Check heart rate, blood pressure, and respiratory rate. 2. Cardiac examination. Listen for irregular heartbeats, murmurs, or signs of heart failure. 3. Thyroid examination. Check for signs of hyperthyroidism, which can cause palpitations. C. Diagnostic testing. 1. Electrocardiogram ECG provides immediate evaluation of heart rhythm during palpitations. 2. Holter monitor or event recorder for intermittent palpitations not captured by a standard ECG. 3. Echocardiogram assesses structural heart disease that could be causing palpitations. 4. Blood tests, thyroid function tests, TFTs, to rule out hyperthyroidism. Electrolyte levels, especially potassium and magnesium. Complete blood count, CBC, to identify anemia. D. Management strategies. 1. Lifestyle modification, reduction in caffeine and alcohol intake. Avoidance of stimulant use, e.g. certain medications, tobacco, recreational drugs. Stress management techniques, such as meditation or yoga. 2. Medical treatment. Beta blockers. First-line treatment for symptomatic palpitations, particularly if they are due to benign arrhythmias or anxiety. Antiarrhythmic drugs for specific arrhythmias identified by diagnostic testing. Treatment of underlying conditions, such as thyroid medication for hyperthyroidism or appropriate management for electrolyte imbalances. 3. Electrophysiological study and ablation, considered if palpitations are caused by a specific arrhythmia amenable to this treatment. 4. Patient education, reassurance about the benign nature of most palpitations. Instructions on how to perform the Valsalva maneuver, which can help terminate some types of supraventricular tachycardia. E. Follow-up and monitoring. Regular follow-ups to assess the effectiveness of management strategies. Adjustment of medications as needed based on symptoms and side effects. Referral to a cardiologist or arrhythmia specialist if symptoms persist or worsen. F. Emergency management. Immediate medical attention if palpitations are accompanied by severe symptoms such as chest pain, severe shortness of breath, or syncope, as these may indicate a more serious condition like a myocardial infarction or significant arrhythmia. This structured approach ensures a thorough evaluation to identify the cause of palpitations and appropriate management to address both symptoms and underlying conditions. Management of fever. Managing fever effectively involves several key steps, focusing not only on reducing fever itself, but also addressing the underlying cause. Here's a structured approach. A. Assessing and stabilizing the patient. Initial assessment. Check vital signs to assess the severity and potential causes of the fever. This includes temperature, heart rate, respiratory rate, and blood pressure. Stabilization. If the patient is severely ill, stabilize them according to the ABCs, airway, breathing, circulation, and consider immediate interventions like fluid resuscitation or oxygen therapy if necessary. B. Diagnostic evaluation. History and physical examination. Detailed history, including travel, exposure, and medical history, and physical examination to identify potential sources of infection, or non-infectious causes of fever. Laboratory and imaging studies. Based on initial findings, order appropriate tests such as complete blood count, CBC, blood cultures, urinalysis and urine culture, chest x-ray, targeted imaging, CT, MRI, or specific tests depending on suspected source, e.g. lumbar puncture for suspected meningitis. C. Specific considerations in fever management. Empiric antibiotic therapy. If bacterial infection is suspected and the patient is significantly ill, consider empiric antibiotics after cultures are obtained but before results are available. Antibiotic choice depends on the likely source and local resistance patterns. Antipyretics. Use medications like acetaminophen or ibuprofen to reduce discomfort associated with fever, though they will not treat the underlying cause. It's important to use these judiciously, especially in patients with liver dysfunction, avoid acetaminophen, or renal impairment, avoid NSAIDs. Hydration and cooling measures. Ensure adequate hydration, and if fever is very high or causing discomfort, consider physical cooling measures like tepid sponging. D. Follow-up and reassessment. Monitor response. Regularly reassess the patient to monitor response to treatment and adjust as needed based on test results and clinical progress. Adjust treatment based on findings. If specific infectious or non-infectious causes are identified, tailor the treatment accordingly. For instance, switch to targeted antibiotic therapy when pathogen sensitivities are known. E. Special cases. Neutropenic fever. High-risk patients, e.g. those with neutropenia following chemotherapy, require immediate empirical antibiotic therapy due to the high risk of severe infections. Fever of unknown origin, FUO, prolonged fever where initial investigations do not reveal a cause. Requires a structured approach with repeated assessments and possibly more invasive diagnostics. F. Education and prevention. Patient education. Inform patients about the importance of monitoring fever and when to seek further medical care. Vaccinations and preventive measures. Ensure appropriate vaccinations and other preventive measures are up to date to minimize the risk of infections that can cause fever. Conclusion. The management of fever involves a comprehensive approach that includes assessment, stabilization, targeted diagnostics, and specific treatment based on the underlying cause. Regular monitoring and adjustments to therapy are crucial for effective management. Fever of unknown origin, FUO, overview and management. Definition: fever of unknown origin, FUO, is traditionally defined as a fever higher than 38.3 degrees Celsius, 100 degrees Fahrenheit, on several occasions over more than 3 weeks, with uncertain diagnosis after 1 week of inpatient investigation or 3 outpatient visits. Categories of FUO. 1. Classic FUO, common in generally healthy individuals. Hospital-acquired FUO, develops in hospitalized patients. Neutropenic O occurs in patients with neutropenia. 4. HIV-associated FO, seen in patients with HIV/AIDS. Diagnostic approach. 1. Detailed history and physical examination. History. Emphasis on travel, animal exposures, occupational hazards, sexual history, drug use, and previous medical interventions. Physical examination, thorough examination, including all organ systems and repeated examinations over time to detect intermittent abnormalities or evolving patterns. 2. Laboratory tests, initial broad screening tests, CBC with differential, liver function tests, renal function tests, urinalysis, inflammatory markers, ESR, CRP, cultures, blood, urine, potentially other fluids depending on symptoms, specific tests based on clues, HIV testing, autoantibody panels, etc. 3. Imaging studies. Chest x-ray, mandatory in all FUO cases. Ultrasound or CT scans, depending on symptoms, focus on abdomen, pelvis, or other regions suggested by the clinical assessment. PET scan can be helpful in identifying hidden sites of inflammation or malignancy. MRI, useful for detecting myelitis, abscesses, or other hidden infections. 4. Specialized tests. Temporal artery biopsy, considered if temporal arteritis is suspected. Bone marrow biopsy, recommended if hematologic malignancy or disseminated infection is suspected. Endoscopic examinations if gastrointestinal sources are suspected. Management principles. 1. Empirical treatment. Generally not recommended unless specific indications exist, e.g., neutropenic patient, severe sepsis signs. If initiated, based on the most likely sources of infection or inflammation guided by clinical and epidemiological clues. 2. Targeted therapy. Initiated once specific causes are identified. Adjust antibiotics based on culture results and sensitivity patterns. Treat underlying non-infectious causes, e.g., connective tissue diseases, malignancies, based on diagnostic findings. 3. Monitoring and follow-up. Regular monitoring for new signs or symptoms. Reevaluate the diagnosis and therapy effectiveness continuously. 4. Consultation with specialists. Infectious disease specialists, rheumatologists, hematologists, or oncologists, depending on the suspected underlying cause. Challenges in management. FUO can be frustrating both for patients and clinicians due to its elusive nature. Long diagnostic process can be anxiety-provoking and costly. Risk of unnecessary diagnostic procedures which may lead to complications. Conclusion. The approach to FUO requires a methodical evaluation, starting with the least invasive methods and progressing to more detailed investigations. Patience and persistence in following up on evolving symptoms and diagnostic clues are crucial for successful resolution of these challenging cases.
Headache, overview and diagnostic approach. Definition: headache is a common clinical complaint characterized by pain in the head, scalp, or neck regions. It is important to distinguish between primary headaches, which are not caused by another condition, and secondary headaches, which result from another underlying health issue. Categories of headache. 1. Primary headaches include migraine, tension-type headache, and cluster headache. 2. Secondary headaches result from underlying causes such as infections, head injury, vascular disorders, or tumors. Diagnostic approach. 1. History taking, onset sudden versus gradual, duration, persistent or episodic, location, generalized or focused, character, throbbing, aching, stabbing, intensity, scale of pain, triggers, stress, foods, environmental factors, associated symptoms, nausea, photophobia, aura. 2. Physical examination, vital signs, especially blood pressure, neurological assessment, check for focal signs, mental status changes, ENT examination, sinuses, ears, eye examination, pupillary responses, fundoscopy. 3. Red flags, SNOOP 10 criteria, systemic symptoms, fever, weight loss, neurological symptoms, seizures, changes in vision. Onset, new headache in an older person. Previous headache history, significant change in attack pattern. Positional, changes with posture. Papilledema suggests increased intracranial pressure. 4. Diagnostic testing, imaging, MRI or CT scan for unexplained or atypical headaches. Lumbar puncture if meningitis or subarachnoid hemorrhage is suspected. Blood tests, CBC, ESR, CRP to rule out infection or inflammation. Special tests depending on suspected cause, e.g., temporal artery biopsy for giant cell arteritis. Management, uh, treat underlying cause if identified. Symptomatic treatment for primary headaches includes NSAIDs, acetaminophen, triptans. Preventive treatments may be considered for frequent or severe headaches, such as beta blockers, antiepileptics, or antidepressants. Follow-up. Regular follow-up to adjust treatment as necessary. Monitor for new symptoms or changes in headache pattern. Prevention. Lifestyle modifications, adequate hydration, regular sleep patterns, stress management. Avoid known triggers such as certain foods or excessive caffeine. Conclusion. Effective management of headaches involves a detailed patient history, thorough physical examination, and selective use of diagnostic tests to identify any underlying causes. Treatment should be tailored to the specific type of headache and individual patient needs. Differential diagnosis of headache, CLOST 1. Primary headaches, tension type headache, most common, often described as a band like pressure around the head with mild to moderate intensity. Migraine, characterized by pulsating pain, usually unilateral, often with nausea, photophobia, or phonophobia, may have aura. Cluster headache, severe unilateral pain around the eye with lacrimation and nasal congestion. Occurs in clusters for weeks to months, followed by remission. 2 secondary headaches due to underlying conditions. Intracranial hemorrhage, subarachnoid, intracerebral, or subdural hemorrhage, sudden onset thunderclap headache, often described as the worst headache of life. Meningitis, infection leading to inflammation of the meninges. Symptoms include headache, fever, neck stiffness, and photophobia. Brain tumors can cause headache due to increased intracranial pressure. Symptoms may worsen in the morning or with position changes. Temporal arteritis, giant cell arteritis, often in patients over 50 years. Symptoms include new headache, jaw claudication, and visual disturbances. Pseudotumor cerebri, idiopathic intracranial hypertension. Features include daily headaches, visual changes, and papilledema without an underlying mass. Cerebral venous sinus thrombosis, headache with varying intensity, visual symptoms, possibly seizures. 3. Headaches with structural causes, sinusitis, pain associated with sinus pressure, worse with bending forward or lying down. Cervicogenic headaches, originating from the neck, often due to structural changes like cervical arthritis. Post-traumatic headaches following head injury, resembling tension type or migraine headaches. 4. Vascular disorders, arterial dissection, carotid or vertebral, sudden onset of pain, often with Horner's syndrome or ischemic stroke symptoms. Hypertensive headache due to high blood pressure, often occipital and present upon waking. 5. Infectious causes, HIV/AIDS, headaches due to either the infection itself or associated opportunistic infections. Systemic infections, such as influenza or mononucleosis, which can also lead to headache. 6. Metabolic causes, hypoglycemia, headaches often accompanied by symptoms of low blood sugar, such as dizziness and sweating. Hypercapnia, high CO2 levels, can lead to headache among other neurological symptoms. Substance-related headaches, carbon monoxide poisoning, often described as a dull, pressure-type headache. Medication overuse headache, due to chronic use of headache medications, particularly triptans and analgesics. Withdrawal headaches from substances such as caffeine or narcotics. 8. Miscellaneous causes, sleep disorders. Sleep apnea and insomnia can exacerbate or cause headaches. Temporal mandibular joint disorder. Pain can radiate to the temples, causing headache. Diagnostic approach. When assessing a patient with headache, it is crucial to use the history and physical exam to guide the selection of appropriate diagnostic tests. Imaging studies such as MRI or CT scans are indicated based on suspicion of secondary causes. Other specific tests, e.g., lumbar puncture, ESR for giant cell arteritis, should be considered when clinical suspicion aligns with such conditions. Conclusion. A structured approach to diagnosis considering both common and life-threatening causes is essential for effective management of headache. Tailoring the diagnostic workup and treatment to individual symptoms and medical history ensures optimal patient care. Malnutrition, overview and clinical approach. A. Characteristics, symptoms, and pathophysiology. Malnutrition refers to deficiencies, excesses, or imbalances in a person's intake of energy and/or nutrients. Types of malnutrition, undernutrition, include stunting, low height for age, wasting, low weight for height, underweight, low weight for age, and micronutrient deficiencies or insufficiencies, lack of important vitamins and minerals. Overnutrition, overweight, obesity, and diet-related non-communicable diseases such as heart disease, stroke, diabetes, and cancer. Pathophysiology. Inadequate intake of nutrients leads to altered body functions, impaired muscle and tissue structure, and eventually diminished ability to digest food, absorb nutrients, and fight off diseases. B. Clinical presentation and diagnosis. Clinical features. Physical signs. Muscle wasting, edema, hair loss, dry skin, and changes in skin pigmentation. developmental delays in children, reduced intellectual ability, and impaired immune function. Psychological effects, apathy, irritability, and reduced cognitive functioning. Diagnostic criteria, anthropometric measurements, body mass index for age, and weight for height. Biochemical tests, serum protein levels, micronutrient levels, and other specific nutrient deficiencies. Clinical assessment, dietary history, symptom presentation, and physical examination for signs of nutrient deficiencies. C, treatment, nutritional rehabilitation, tailored nutrient-rich diets, supplementation programs, e.g., vitamin A for children, iron supplementation for anemic patients. Medical treatment, addressing underlying causes such as infections or chronic diseases that exacerbate malnutrition. Monitoring and support, regular follow-up to monitor nutritional status, adjust dietary plans, and provide social and psychological support. D, prognosis, varies widely based on the cause, severity, and timing of intervention. Early detection and intervention can lead to a full recovery, but long-term neglect can result in permanent damage or increased mortality risk. E, prevention and public health strategies. Educational programs to promote balanced eating habits, food fortification programs to address micronutrient deficiencies, community-based health initiatives focusing on improving access to nutritious foods and healthcare services. Conclusion. Malnutrition encompasses a broad spectrum of nutrient-related disorders that can cause significant morbidity and mortality. Effective management requires a comprehensive approach involving accurate diagnosis, appropriate nutritional and medical intervention, and ongoing monitoring. Public health strategies play a crucial role in prevention and management, aiming to ensure equitable access to essential nutritional resources for vulnerable populations. Abdominal examination, a comprehensive guide. A, characteristic symptoms and pathophysiology. Purpose, to identify any signs of abdominal pathology which may indicate underlying health conditions ranging from gastrointestinal disorders to systemic diseases. Techniques, consists of inspection, auscultation, percussion, and palpation, each serving specific purposes in identifying abnormalities. B, clinical presentation and diagnosis, inspection, observe for abnormalities such as scars, distension, and color changes. Key observations include movements, e. peristaltic waves, and any visible pulsations. Auscultation, performed to assess bowel sounds and the presence of vascular noises like bruits. Normal bowel sounds occur every 5 to 10 seconds. Variations may indicate disorders like bowel obstruction or ischemia. Percussion, helps assess the presence of fluid, masses, or organomegaly. Tympany is typically heard over the gastric bubble and dullness over the liver and spleen. Palpation includes both light and deep palpation to check for tenderness, masses, liver size, and spleen consistency. Special maneuvers like Murphy's sign may be used to evaluate specific conditions such as gallbladder disease. C. Treatment. Based on the findings from the abdominal examination, treatment can range from dietary modifications and medications to surgical interventions, depending on the underlying cause identified during the examination. D. Prognosis. The outcome is highly dependent on the underlying condition diagnosed during the examination. Early detection and appropriate management can lead to a favorable prognosis in many abdominal disorders. E. Differential diagnosis, Upper abdomen pain. Conditions like gastritis, peptic ulcer disease, pancreatitis, gallstones, and hepatic disorders. Mid-abdomen pain, issues such as intestinal obstructions, appendicitis, and mesenteric ischemia. Lower abdomen pain includes causes like diverticulitis, urinary tract infections, and gynecological maladies. Diffuse abdominal pain could indicate peritonitis, gastroenteritis, or systemic infections. Conclusion: the abdominal examination is a fundamental aspect of physical diagnosis in medicine, crucial for identifying a wide array of conditions affecting not only the gastrointestinal tract, but also the systemic health of patients. Mastery of this examination technique is essential for effective clinical assessment and management of abdominal complaints. Hepatomegaly, common causes and overview. A. Characteristic symptoms and pathophysiology. Hepatomegaly refers to the abnormal enlargement of the liver beyond its normal size. It is often a sign of an underlying disease affecting liver function or causing congestion. B. Clinical presentation and diagnosis. Presentation: the liver edge may be palpable below the right costal margin in the mid-clavicular line. Patients might not present with pain unless there is a rapid increase in size due to stretching of the liver capsule. Diagnostic tools: physical examination, liver edge palpation, liver span measured by percussion. Imaging: ultrasound is the primary imaging modality, but CT and MRI can provide more detailed information. Blood tests, liver function tests, LFTs, including ALT, AST, bilirubin levels, and alkaline phosphatase. C. Common causes of hepatomegaly. 1. Infectious causes, viral hepatitis. Hepatitis A, B, C, D, and E can cause liver inflammation leading to enlargement. Mononucleosis, Epstein-Barr virus infection can result in hepatosplenomegaly. Parasitic infections, conditions like schistosomiasis can cause liver enlargement. 2. Alcoholic liver disease. Chronic alcohol consumption can lead to fatty liver, hepatitis, and cirrhosis, all of which may present with hepatomegaly. Non-alcoholic fatty liver disease, NAFLD, associated with obesity, diabetes, and metabolic syndrome. It's becoming increasingly common in the general population. 4. Congestive heart failure. Right heart failure can lead to passive congestion of the liver, often seen with jugular venous distension and peripheral edema. 5. Cirrhosis. Resulting from chronic liver diseases, cirrhosis can lead to hepatomegaly initially, followed by liver shrinkage in later stages. 6. Malignancies. Primary liver cancer, hepatocellular carcinoma, or metastatic cancers from other sites. 7. Hematologic diseases. Conditions such as leukemia and myeloproliferative disorders can cause liver enlargement due to infiltration or congestion. 8. Storage diseases. Genetic disorders like Gaucher's disease and Wilson's disease can lead to accumulation of substances causing liver enlargement. D. Treatment. Treatment strategies are highly dependent on the underlying cause. Management might include antiviral therapy for hepatitis, lifestyle changes, and medications for NAFLD, and appropriate heart failure management. In some cases, such as certain cancers, surgical interventions may be necessary. E. Prognosis. The prognosis for hepatomegaly varies widely and is contingent on the underlying cause, the extent of liver involvement, and the overall health of the patient. Early diagnosis and targeted treatment of the primary condition are crucial for improving outcomes. Conclusion: understanding the underlying cause of hepatomegaly is essential for effective management. A thorough clinical evaluation complemented by diagnostic testing is imperative for appropriate treatment planning and prognosis assessment. TACH, acute abdomen, common causes and overview. A. Characteristic symptoms and pathophysiology. Acute abdomen refers to sudden, severe abdominal pain that may indicate serious, potentially life-threatening conditions. It demands rapid diagnosis and often urgent medical or surgical treatment. B. Clinical presentation and diagnosis. Presentation typically involves severe abdominal pain that can be localized or diffuse, often accompanied by signs such as rebound tenderness, guarding, and systemic symptoms like fever or hypotension. Diagnostic approach, physical examination, includes assessing for peritoneal signs, rigidity, and location-specific pain. Imaging, urgent imaging such as an abdominal ultrasound, X-ray, or CT scan depending on the suspected underlying cause. Laboratory tests, basic metabolic panel, BMP, complete blood count, CBC, liver function tests, LFTs, lipase, and depending on the clinical scenario, markers like lactate and troponin. DAS C. Common causes of acute abdomen. 1. Inflammatory causes. Appendicitis commonly presents with right lower quadrant pain. Diverticulitis typically causes left lower quadrant pain in older adults. Cholecystitis. Inflammation of the gallbladder, often associated with right upper quadrant pain, fever, and leukocytosis. 2. Obstructive causes. Bowel obstruction can be due to adhesions, hernias, or tumors. Presents with colicky pain, vomiting, and abdominal distension. Ureteral stones cause severe flank pain radiating to the groin, often with hematuria. 3. Perforative causes. Peptic ulcer disease. Perforation leads to sudden, severe, and diffuse abdominal pain with a rigid abdomen. Bowel perforation, secondary to conditions like diverticulitis or inflammatory bowel disease. 4. Ischemic causes. Mesenteric ischemia, acute onset of pain, often out of proportion to physical findings in the elderly or those with atrial fibrillation or previous vascular interventions. 5. Infectious causes. Gastroenteritis can sometimes present acutely with severe pain, especially if associated with complications like severe dehydration or toxic megacolon. Pelvic inflammatory disease, PID, especially in sexually active women presenting with lower abdominal pain. 6. Vascular causes. Ruptured aortic aneurysm presents with severe back or abdominal pain, hypotension, and a pulsatile abdominal mass. Aortic dissection, severe pain with a tearing sensation radiating to the back. Ectopic pregnancy, in sexually active women of reproductive age presenting with unilateral lower abdominal pain and vaginal bleeding. D. Treatment. Management strategy. Initial management focuses on stabilization, pain control, and addressing the underlying cause. Surgical intervention may be necessary for conditions like appendicitis, cholecystitis, or any condition involving perforation or obstruction. Surgical consultation, often required urgently to assess the need for operative intervention. E. Prognosis. The prognosis for acute abdomen varies greatly depending on the underlying cause, but is generally improved with rapid diagnosis and appropriate intervention. Conclusion: the management of an acute abdomen requires swift assessment and action to mitigate the risk of serious complications like sepsis and organ failure. A multidisciplinary approach involving emergency physicians, surgeons, and sometimes interventional radiologists is essential for optimal outcomes. Diagnosis of abdominal pain, a comprehensive guide. A. Characteristic symptoms and pathophysiology. Abdominal pain can arise from a variety of gastrointestinal, genitourinary, vascular, and systemic conditions. Understanding the specific characteristics such as onset, location, and nature of the pain helps in identifying the underlying cause. B. Clinical presentation and diagnosis. 1. History taking. Onset and duration. Sudden versus gradual onset can distinguish between acute conditions like appendicitis and chronic issues like irritable bowel syndrome. Location pinpoints possible organs involved, e.g., right lower quadrant pain may suggest appendicitis. Nature and intensity. Sharp, stabbing pain might suggest perforation or obstruction, whereas a dull, aching pain might be more consistent with an infectious or inflammatory process. Exacerbating relieving factors. Eating might worsen ulcer pain, but could relieve pain from duodenal ulcers. Associated symptoms: nausea, vomiting, diarrhea, constipation, fever, jaundice, and changes in urination or stool characteristics provide significant diagnostic clues. 2. Physical examination, inspection. Look for scars, distension, or visible peristalsis. Auscultation. Listen for bowel sounds, hyperactive in obstruction, hypoactive or absent in peritonitis. Percussion helps assess ascites or generalized tenderness. Palpation, check for localized tenderness, rebound tenderness, masses, or organomegaly. 3. Special tests. Rebound tenderness indicates peritoneal irritation. Murphy's sign, elicited in acute cholecystitis. Rovsing's sign, psoas sign, obturator sign, utilized in diagnosing appendicitis. Digital rectal exam assesses for masses, bleeding, or tenderness in the lower gastrointestinal tract. C. Diagnostic imaging and laboratory tests. 1. Laboratory tests. Complete blood count, CBC, can indicate infection or inflammation. Liver function tests, LFTs. Elevations can suggest hepatobiliary disease. Amylase and lipase. Elevated levels may indicate pancreatitis. Urinalysis helps diagnose urinary tract infections or nephrolithiasis. 2 imaging studies. Abdominal X-ray, useful for detecting free air, bowel obstruction, or stones. Ultrasound, first line for gallbladder disease, liver disease, and gynecological problems. Computed tomography C-scan provides detailed images beneficial for diagnosing diverticulitis, appendicitis, and bowel obstruction. MRI, used in special circumstances, such as for patients who cannot be exposed to radiation. 3 additional tests. Endoscopy, for direct visualization of the gastrointestinal tract to assess for ulcers, malignancies, or bleeding. Pregnancy tests should be done in any female of childbearing age presenting with abdominal pain to rule out pregnancy-related causes. D. Treatment and management. Initial management includes pain relief, fluid resuscitation, and, where appropriate, antibiotics. Specific treatments depend on the underlying diagnosis, ranging from surgical intervention for conditions like appendicitis to medical management for ulcers or gastroenteritis. E. Prognosis depends on the underlying cause of the abdominal pain. Early diagnosis and appropriate treatment are crucial to improve outcomes and minimize complications. Conclusion: diagnosing abdominal pain requires a methodical approach involving thorough history taking, physical examination, targeted diagnostics, and appropriate management strategies to address the broad spectrum of potential underlying causes. Diagnosing abdominal pain, a comprehensive approach. Abdominal pain is a common clinical complaint that can range from mild discomfort to severe acute pain, necessitating immediate medical attention. The process of diagnosing abdominal pain involves several systematic steps to identify the underlying cause. Characteristic symptoms and pathophysiology: visceral pain, often dull, poorly localized, resulting from organ distension or ischemia, commonly associated with gastrointestinal disorders. Parietal pain, sharp and well localized, arising from irritation of the parietal peritoneum, as seen in conditions like peritonitis. Referred pain, pain felt at a location distant from the source. For example, gallbladder inflammation may cause right shoulder pain. B. Clinical presentation and diagnosis. 1. History taking, character of pain, description: sharp, dull, cramping, onset, duration, and any sudden changes in intensity. Location helps localize the potential organ involved. For instance, right upper quadrant pain could suggest gallbladder issues, while lower abdominal pain might suggest appendicitis or gynecological issues. Aggravating and alleviating factors: meals, movement, posture, or medications that affect the pain. Associated symptoms: nausea, vomiting, diarrhea, fever, jaundice, and changes in bowel habits or urinary symptoms. 2. Physical examination, inspection. Look for scars, distension, discoloration. Auscultation. Bowel sounds can be hyperactive in bowel obstruction or absent in peritonitis. Percussion, tenderness, distension, and fluid wave tests for ascites. Palpation, localization of pain, rebound tenderness, guarding, and rigidity. 3. Special tests: Murphy's sign for cholecystitis, Rovsing's sign for appendicitis, obturator and psoas signs, also for appendicitis. Rectal and vaginal examinations to check for masses, tenderness, or other pathological signs in the lower gastrointestinal tract or pelvis. C. Diagnostic imaging and laboratory tests. 1. Laboratory tests: complete blood count, CBC, to detect infection or inflammation. Liver function tests, LFTs, to assess liver status. Amylase and lipase levels can indicate pancreatitis. Urinalysis, to diagnose urinary tract infections or renal stones. 2. Imaging studies, abdominal ultrasound, useful for evaluating gallbladder disease, liver problems, and pelvic issues. X-rays can identify obstructions, free air, and sometimes stones. CT scan provides a detailed view, useful for diagnosing diverticulitis, appendicitis, and bowel obstructions. MRI, used for detailed imaging when CT is contraindicated. 3. Further diagnostic tests: endoscopy for gastrointestinal bleeding, malignancy, or inflammatory bowel disease. Colonoscopy for lower gastrointestinal issues such as colorectal cancer or polyps. D. Differential diagnosis: acute versus chronic. Duration and onset of symptoms can distinguish between acute conditions like appendicitis and more chronic conditions such as ulcers or cancer. By location, right lower quadrant pain may suggest appendicitis. Epigastric pain might indicate peptic ulcer disease. By nature, colicky pain could indicate a blockage, while steady, severe pain may suggest an inflammatory process. E. Treatment and management. Specific treatments depend on the underlying cause, ranging from surgical intervention for appendicitis to medical management for conditions like gastroenteritis. Supportive care, pain management, hydration, and sometimes dietary adjustments are crucial. F. Prognosis. Prognosis varies widely based on the underlying condition, from benign issues that resolve with minimal treatment to serious conditions requiring surgery or long-term management. Conclusion: a thorough assessment combining clinical evaluation, laboratory testing, imaging, and sometimes more invasive diagnostics is crucial to effectively diagnose and manage abdominal pain. Early and accurate diagnosis can significantly improve outcomes, especially in acute conditions. Dysphagia, or difficulty swallowing, can be categorized into two primary types, oropharyngeal and esophageal, each with distinct causes and implications for diagnosis and management. A. Oropharyngeal dysphagia. This type involves problems with the initiation of swallowing and is often related to disorders affecting the throat, the neurological control of swallowing, or both. Characteristic symptoms and pathophysiology. Difficulty starting the swallow, possible aspiration of food or liquids, sensation of food sticking in the throat, nasopharyngeal regurgitation or coughing, choking during meals. Common causes: 1. Neurological disorders: stroke, Parkinson's disease, multiple sclerosis, amyotrophic lateral sclerosis, ALS, myasthenia gravis. 2. Structural abnormalities: Zenker's diverticulum, cervical web, tumors of the throat or base of the tongue. 3. Muscular disorders: dermatomyositis, polymyositis. 4. Infections and inflammatory conditions: epiglottitis, pharyngitis. B. Esophageal dysphagia. This type is associated with the sensation of food being stuck after swallowing has initiated, typically indicating an issue within the esophagus itself. Characteristic symptoms and pathophysiology: sensation of food sticking after swallowing, chest pain or discomfort, regurgitation of food. Common causes: 1. Mechanical obstructions, esophageal strictures from acid reflux, radiation, or ingestion of caustic substances, esophageal rings and webs, e.g. Schatzky ring, esophageal cancer. 2. Motility disorders. Achalasia, characterized by failure of the lower esophageal sphincter to relax, esophageal spasm, irregular, painful contractions of the esophageal muscles. Scleroderma affects motility of the entire esophagus. 3. Gastroesophageal reflux disease, GERD, can lead to scarring and narrowing of the esophagus associated with chronic heartburn. 4. Eosinophilic esophagitis, an allergic response that can cause esophageal narrowing. 5. Extrinsic compression, tumors or enlarged lymph nodes pressing on the esophagus, anomalies in vascular structure compressing the esophagus. Diagnostic evaluation. The approach to diagnosing dysphagia includes a thorough clinical history, physical examination, and specialized tests. Barium swallow study helps visualize structural and some motility issues. Endoscopy. Direct visualization of the esophagus allows for biopsy if needed. Manometry assesses esophageal motility and function of sphincters. pH monitoring identifies excessive acid reflux affecting the esophagus. Treatment. Treatment strategies vary significantly based on the underlying cause. Neurological and muscular disorders often involve swallowing therapy and management of the primary disease. Structural abnormalities may require endoscopic or surgical intervention to remove or bypass obstructions. Motility disorders, pharmacological agents to improve motility, or procedures like dilation or botulinum toxin injections for achalasia. GERD and eosinophilic esophagitis, dietary management, medications to reduce acid and inflammation, and avoidance of allergens. Prognosis. The prognosis for dysphagia depends on the underlying cause, with some conditions being manageable with medical treatment and lifestyle adjustments, while others may require more invasive interventions or have a more guarded prognosis due to progressive systemic diseases. Dysphagia, or difficulty swallowing, can be caused by a variety of conditions that affect either the oropharyngeal or the esophageal phases of swallowing. These conditions can be broadly classified into two categories: oropharyngeal dysphagia and esophageal dysphagia, each associated with distinct pathologies. Oropharyngeal dysphagia. This type of dysphagia is related to difficulties starting the swallowing process, often involving the mouth, throat, or upper esophageal area. It can be caused by neurological disorders. Issues such as stroke, Parkinson's disease, multiple sclerosis, or amyotrophic lateral sclerosis can impair the nerves or muscles involved in swallowing. Muscular disorders. Conditions like myasthenia gravis or muscular dystrophies weaken the muscles needed for effective swallowing. Structural abnormalities. Anatomical issues such as Zenker's diverticulum, tumors, or congenital abnormalities can physically obstruct the throat or upper esophagus. Infections or inflammatory conditions. Infections like epiglottitis or tonsillitis and inflammatory conditions such as sarcoidosis or autoimmune diseases, e.g., rheumatoid arthritis, Sjogren's syndrome, can cause swelling that interferes with swallowing. Esophageal dysphagia. This type involves the passage of food through the esophagus to the stomach and can be caused by mechanical obstructions. Conditions such as esophageal cancer, strictures, or external compression from tumors or enlarged lymph nodes can narrow the esophagus. Motility disorders. Disorders like achalasia, esophageal spasm, or scleroderma affect the ability of the esophagus to move food toward the stomach. Gastroesophageal reflux disease, GERD. Chronic acid reflux can lead to narrowing of the esophagus from scar tissue, strictures, or the development of Barrett's esophagus. Eosinophilic esophagitis, an allergic condition that can cause inflammation and narrowing of the esophagus. Infectious esophagitis, infections particularly in immunocompromised individuals, can cause esophageal inflammation and ulcers. Diagnostic evaluation. The approach to diagnosing dysphagia includes clinical evaluation, distinguishing between oropharyngeal and esophageal dysphagia, understanding the nature of the swallowing difficulty with solids, liquids, or both, and identifying any associated symptoms or risk factors. Barium swallow study, useful for visualizing structural changes and motility patterns in the esophagus. Endoscopy, direct inspection of the esophagus and stomach can identify inflammation, tumors, or other structural abnormalities. Biopsies can be taken if needed. Manometry, assesses the motility and functioning of the esophagus and esophageal sphincters. pH monitoring helps in diagnosing GERD by measuring acid exposure in the esophagus. Management treatment depends on the underlying cause but may include dietary modifications, changing food textures and sizes to facilitate easier swallowing. Swallowing therapy, techniques to improve swallowing safety and efficiency, often guided by a speech and language therapist. Medication, use of drugs to treat underlying conditions like acid reflux, eosinophilic esophagitis, or to improve esophageal motility. Surgical or endoscopic procedures. These might be necessary for structural abnormalities like strictures, diverticula, or tumors. The prognosis and management strategies are highly dependent on the specific etiology of the dysphagia, making a detailed and thorough diagnostic evaluation crucial for effective treatment planning. Nausea and vomiting are common symptoms that can be triggered by a variety of conditions, ranging from mild and self-limiting to serious and life-threatening. Here's a breakdown of the potential causes of nausea and vomiting based on different categories. Gastrointestinal causes. Gastroenteritis, viral or bacterial infections causing inflammation of the stomach and intestines. Peptic ulcer disease, PUD. Ulcers in the stomach or duodenum can cause nausea and vomiting, especially when the stomach is empty. Gastritis, inflammation of the stomach lining, often due to Helicobacter pylori infection, NSAIDs, or alcohol. Gastroesophageal reflux disease, GERD. Acid reflux can lead to vomiting, especially after meals or at night. Bowel obstruction, mechanical obstruction in the intestines, can cause vomiting, often with a history of surgery or hernias. Cholecystitis, inflammation of the gallbladder, typically presenting with right upper quadrant abdominal pain, fever, and vomiting. Pancreatitis, inflammation of the pancreas, often associated with severe epigastric pain radiating to the back. Central nervous system causes. Migraines, severe headache disorder that can also involve nausea and sensitivity to light and sound. Meningitis, infection of the meninges around the brain and spinal cord, presenting with fever, headache, stiff neck, and nausea. Brain tumors can cause increased intracranial pressure, leading to morning nausea and vomiting. Hydrocephalus, increased fluid in the brain cavities, can cause pressure effects, including nausea. Endocrine metabolic causes. Diabetic ketoacidosis, a serious complication of diabetes presenting with nausea, vomiting, abdominal pain, and dehydration. Hypercalcemia, high calcium levels can cause nausea, vomiting, constipation, and abdominal pain. Addison's disease, adrenal insufficiency, can present with nausea, vomiting, fatigue, and low blood pressure. Toxic ingestions and medications, alcohol intoxication or withdrawal. Drug side effects, many medications including antibiotics, NSAIDs, and chemotherapeutic agents can cause nausea as a side effect. Poisoning, ingestion of toxic substances can lead to acute nausea and vomiting. Pregnancy-related causes, morning sickness, common in early pregnancy. Hyperemesis gravidarum, severe nausea and vomiting in pregnancy that can lead to weight loss and dehydration. Other causes, vestibular disorders. Issues such as labyrinthitis or Meniere's disease affect the inner ear and balance, leading to vertigo associated with nausea and vomiting. Postoperative nausea and vomiting, PONV, common after anesthesia and certain types of surgery. Psychogenic causes, such as bulimia or anxiety disorders. Diagnostic approach. To determine the underlying cause of nausea and vomiting, a thorough history and physical examination are crucial. Diagnostic tools may include blood tests to check for metabolic, liver, and pancreatic disorders. Imaging, such as ultrasound or CT scans for abdominal issues. Endoscopy, for direct visualization of the gastrointestinal tract. Neuroimaging, MRI or CT scan of the brain if a central cause is suspected. Management treatment of nausea and vomiting depends on the underlying cause, but generally includes rehydration, oral or IV fluids to address dehydration, antiemetics, medications to control nausea and vomiting, dietary adjustments, small, frequent meals and avoiding triggers such as fatty or spicy foods, treating underlying conditions such as antibiotics for infections or surgery for obstructions. Prompt identification and management of the underlying cause are essential to prevent complications and improve outcomes. Nausea and vomiting are symptoms that can be caused by a wide range of conditions affecting various systems within the body. Here's a detailed overview of the potential causes. Gastrointestinal causes. Gastroenteritis, viral or bacterial infections that inflame the stomach and intestines. Peptic ulcer disease, ulcers in the stomach or duodenum that cause irritation. Gastritis, inflammation of the stomach lining, often due to infection, drugs, or alcohol. Gastroesophageal reflux disease, GERD, acid reflux irritating the esophagus. Bowel obstruction, blockages that prevent food from passing through the intestines. Cholecystitis, inflammation of the gallbladder, often related to gallstones. Pancreatitis, inflammation of the pancreas, which can be acute or chronic. Hepatitis, inflammation of the liver affecting its function. Central nervous system causes, migraines, severe headaches that frequently include nausea and sensitivity to light. Brain tumors can increase intracranial pressure, causing morning nausea. Meningitis, infection of the protective membranes covering the brain and spinal cord. Hydrocephalus, accumulation of cerebrospinal fluid in the brain cavities. Endocrine metabolic causes, diabetic ketoacidosis, DKA, a severe complication of diabetes with high blood sugar levels. Hypercalcemia, elevated calcium levels in the blood can affect various body functions. Addison's disease, a deficiency in adrenal gland hormones causing nausea, among other symptoms. Ear and labyrinth disorders. Meniere's disease, inner ear disorder that affects balance and hearing. Vestibular neuritis, inflammation of the vestibular nerve causing severe vertigo. Pregnancy-related causes. Morning sickness, common in the first trimester of pregnancy. Hyperemesis gravidarum, severe nausea and vomiting in pregnancy, leading to weight loss and dehydration. Medication and toxic ingestions. Drug side effects. Many medications, including chemotherapy, antibiotics, and pain medications, can cause nausea. Alcohol and drug use, overuse or withdrawal from alcohol and drugs like opioids. Toxic ingestions. Poisoning from substances like heavy metals or carbon monoxide. Psychological factors, eating disorders such as anorexia nervosa and bulimia nervosa. Anxiety and stress, psychological distress can manifest physically as nausea. Infectious diseases, traveler's diarrhea, infections contracted from contaminated food or water in another country. Food poisoning, ingestion of contaminated food leading to acute gastrointestinal distress. Miscellaneous, motion sickness, due to movement in cars, boats, or planes. Postoperative nausea and vomiting, PONV, common after anesthesia and certain surgical procedures. Radiation therapy can cause nausea, especially when the abdomen is exposed to radiation. Diagnostic approach, thorough history and physical exam to identify any associated symptoms or potential exposures. Laboratory tests such as blood tests, liver function tests, pregnancy tests, and urine analysis. Imaging such as abdominal ultrasound or CT scan to look for obstructions or other abnormalities. Endoscopy to directly visualize the upper gastrointestinal tract if a gastric cause is suspected. Management. Managing nausea and vomiting involves treating the underlying cause when identified, using antiemetics to control the symptoms, and ensuring hydration and electrolyte balance are maintained. Diarrhea is characterized by the passage of 3 or more loose or watery stools per day, or more frequent passage than is normal for the individual. It can be categorized into 3 types based on duration. 1. Acute diarrhea lasts less than 14 days and is typically caused by an infection, such as viruses like norovirus and rotavirus, bacteria like E. coli and salmonella, or parasites like giardia. It is usually self-limiting. 2. Persistent diarrhea lasts between 15 and 30 days. Infectious agents are also common causes, and diagnostic testing for pathogens may be warranted. 3. Chronic diarrhea lasts longer than 30 days and can be caused by a variety of conditions, including inflammatory bowel diseases, Crohn's disease and ulcerative colitis, malabsorption syndromes like celiac disease, chronic infections, and functional disorders like irritable bowel syndrome, IBS. Etiologies, infectious, often results from consuming contaminated food or water. Viruses, bacteria, and parasites are the primary infectious agents. Non-infectious can be caused by diseases like celiac disease, Crohn's disease, ulcerative colitis, and irritable bowel syndrome. Other causes include medications, e.g., antibiotics, toxins, and metabolic disorders. Diagnostic approach. Acute diarrhea often requires no testing unless there are red flags such as blood in stools, severe dehydration, or systemic illness. Persistent and chronic diarrhea requires comprehensive testing, including stool tests for pathogens, blood tests for systemic illness, and possibly imaging or endoscopy to look for underlying disease. Management. Supportive care primarily involves hydration and electrolyte management. Oral rehydration solutions are typically sufficient for mild cases, while intravenous fluids may be needed for severe cases. Antidiarrheal medications, such as loperamide, may be used in some cases but are contraindicated in others, such as infectious diarrhea with high fever or bloody stools. Antibiotics, indicated only for certain bacterial infections, and should be used based on culture results or strong clinical suspicion of specific pathogens. Dietary management. In cases of chronic diarrhea, identifying and managing dietary triggers can be crucial. Preventive measures. Hygiene and sanitation. Proper hand washing and safe food preparation can prevent many infectious causes. Vaccination, such as the rotavirus vaccine for children, can prevent specific viral infections. Diarrhea is a common symptom that can range from a mild temporary condition to a sign of a serious or chronic health issue. Identifying the underlying cause is essential for appropriate management and treatment. Diarrhea can be caused by a wide range of factors, and its etiology can generally be categorized into infectious, non-infectious, and functional causes. Diarrhea is Diarrhea can be caused by a wide range of factors, and its etiology can generally be categorized into infectious, non-infectious, and functional causes. Here's a detailed overview of each. Infectious causes: viruses, Common viral causes include norovirus, rotavirus, and adenovirus. These are typically spread through the fecal-oral route and are often responsible for outbreaks in daycare centers, schools, and healthcare settings. Bacteria. Bacterial causes of diarrhea include Escherichia coli, various strains including enterotoxigenic, enterohemorrhagic, Salmonella, Shigella, and Campylobacter. These infections can result from eating contaminated food or water. Parasites. Protozoan parasites like Giardia lamblia, Cryptosporidium, and Entamoeba histolytica can cause diarrhea, particularly in travelers or in contaminated water supplies. Non-infectious causes. Chronic diseases. Conditions such as inflammatory bowel disease, Crohn's disease, and ulcerative colitis, celiac disease, and irritable bowel syndrome can lead to chronic diarrhea. Medications. Antibiotics, antacids containing magnesium, chemotherapy drugs, and a wide range of other medications can induce diarrhea as a side effect. Food intolerances and allergies, lactose intolerance, fructose intolerance, and allergies to other specific foods can cause diarrhea. Toxins. Toxins from contaminated foods, such as from staphylococcal food poisoning or botulism, can cause severe diarrhea. Functional causes, functional diarrhea. This includes conditions like irritable bowel syndrome, IBS, where diarrhea occurs without an obvious infection or structural abnormality. Other causes, endocrine disorders. Conditions like hyperthyroidism, Addison's disease, and diabetes mellitus can lead to diarrhea. Malabsorptive and maldigestion disorders. These include pancreatic insufficiency, bile acid malabsorption, and conditions leading to fat malabsorption. Surgical causes. Post-surgical changes, particularly after gastrointestinal surgery, can cause diarrhea. This includes post-cholecystectomy syndrome and consequences of gastric bypass surgery. Ischemic gut, reduced blood flow to the intestines, often seen in older adults with vascular disease, can cause ischemic colitis, leading to diarrhea. Understanding the cause of diarrhea is crucial for effective management, particularly in distinguishing between cases that will resolve spontaneously and those that require specific treatments or interventions. Constipation can be caused by a variety of factors grouped into primary, functional, and secondary categories. Primary constipation, functional constipation. This type typically has no identifiable medical cause and includes 1. Normal transit constipation, the most common form where individuals experience the symptoms of constipation but have a normal rate of stool passing through the colon. 2. Slow transit constipation, characterized by a slower than normal movement of stool through the colon. 3. Defecatory disorders. Outlet obstruction involves difficulty in stool evacuation due to functional issues at the rectum or anus, such as pelvic floor dyssynergia. Secondary constipation, caused by identifiable medical conditions, medications, or lifestyle factors. Medical conditions. Neurological disorders, Parkinson's disease, multiple sclerosis, stroke, spinal cord injuries. Metabolic and endocrine issues, diabetes, hypothyroidism, hypercalcemia. Structural problems, anal fissures, bowel obstruction, colon cancer, rectal prolapse. Systemic diseases, lupus, scleroderma. Medications, opioids, anticholinergics, antidepressants, iron supplements, calcium channel blockers, and diuretics. Diet and lifestyle factors, low fiber intake, poor hydration, lack of physical activity. Acute constipation may be triggered by sudden changes in diet or activity. Hospitalization, often related to limited mobility and dietary changes. Recent surgery, especially abdominal or pelvic surgery, which may interfere with bowel movements due to pain or use of narcotics. Specific situations, fecal impaction, often seen in elderly patients, characterized by a hard mass of stool that cannot be expelled. Opioid-induced constipation, a common side effect of opioid medication use. Understanding the underlying cause of constipation is crucial for effective treatment, which may involve dietary adjustments, lifestyle changes, medications, and in some cases, addressing underlying medical conditions. Constipation can occur due to a variety of reasons, classified broadly into primary, functional constipation, and secondary constipation due to identifiable causes. Primary constipation, functional constipation. This type has no identifiable medical cause and includes normal transit constipation, most common, with normal bowel movement frequency but symptoms of constipation. Slow transit constipation, slower movement of stools through the colon, defecatory disorders, outlet dysfunction, difficulty evacuating stools due functional problems such as anismus or pelvic floor dyssynergia. Secondary constipation caused by underlying medical conditions, lifestyle factors, or medications, medical conditions, neurological disorders, Parkinson's disease, multiple sclerosis, spinal cord injuries, metabolic and endocrine disorders, hypothyroidism, diabetes, hypercalcemia, structural abnormalities, colon cancer, anal fissures, rectal prolapse, intestinal obstruction, systemic diseases, scleroderma, lupus, opioids, anticholinergics, antidepressants, iron supplements, and calcium channel blockers, lifestyle factors, low fiber diet, inadequate fluid intake, lack of physical activity, Lerchash. Specific conditions and situations. Fecal impaction, often seen in elderly or bedridden patients, resulting from accumulated hard stool that cannot be passed. Opioid-induced constipation. Opioids are known to inhibit gastrointestinal motility, leading to constipation. Dietary factors. Insufficient dietary fiber and fluid intake can lead to constipation. The management of constipation varies depending on its cause, ranging from dietary and lifestyle adjustments to pharmacological interventions and, in some cases, treatment of underlying health issues. Gastrointestinal GI bleeding is a serious condition that can present in various forms and be caused by multiple etiologies, requiring rapid assessment and intervention. Here's a summary of the critical points regarding GI bleeding. Classification: upper GI bleeding, UGIB, bleeding originating proximal to the ligament of Treitz. Common causes include peptic ulcers, esophagitis, and varices. Lower GI bleeding, LGIB, bleeding originating distal to the ligament of Treitz, typically from sources such as diverticulosis, colorectal cancer, or hemorrhoids. Occult GI bleeding. Small amounts of bleeding not visible to the naked eye, but detectable through tests like fecal occult blood. Overt GI bleeding, visible signs of bleeding such as hematemesis, melena, or hematochezia. Etiology, UB causes: peptic ulcer disease, gastric or esophageal varices, erosive gastritis, Mallory-Weiss-Tier, esophageal cancer. LGI causes: diverticulosis, colorectal cancer, inflammatory bowel disease, ischemic colitis, angiodysplasia. Clinical presentation: hematemesis, vomiting of blood indicating UGIB. Melena, black, tarry stools, usually from UGIB, but possible from LGIB if the bleed is slow. Hematochezia, passage of fresh blood per rectum, typically indicative of LGIB, but can result from a brisk GI. Management. Initial steps: hemodynamic stabilization, NPO status, IV access, and blood work, including a complete blood count and typing and screening. Diagnostic procedures: endoscopy, first line for both UGIB and LGIB to identify the source and possibly treat it. Colonoscopy, used primarily for LGI but can follow an upper endoscopy if the upper GI source is excluded. Angiography, employed if endoscopic methods fail or are inconclusive, useful for locating the bleeding site and allowing for therapeutic embolization. Treatment focuses on stopping the bleed through endoscopic techniques, angiographic interventions, or surgery, and addressing the underlying cause. Risk stratification helps in guiding the urgency of intervention and the appropriate level of care, using scoring systems like the Glasgow-Blatchford score for UGIB or assessing clinical signs for LGIB. Prompt and effective management of GI bleeding is crucial to prevent complications such as hypovolemic shock, organ failure, and death. Establishing the source and cause of bleeding is vital for targeted treatment and better outcomes. Management of gastrointestinal GI bleeding involves several critical steps focused on stabilizing the patient, diagnosing the source, and controlling the hemorrhage. Here's a comprehensive approach. Initial management. 1. Stabilization. Assessment of airway, breathing, and circulation, ABCs. Ensure the patient's airway is protected, especially if there is active vomiting or reduced consciousness. Fluid resuscitation. Administer intravenous fluids to stabilize hemodynamics. Use crystalloids like normal saline or Ringer's lactate. Blood transfusion. Consider transfusing packed red blood cells if hemoglobin is below 7 gross per L or higher thresholds if the patient is hemodynamically unstable or has significant comorbidities. 2. NPO status. The patient should not eat or drink until a definitive management plan is established. 3. Venous access. Secure 2 large-bore IV lines for fluid and blood administration. 4. Laboratory tests. Complete blood count, CBC, coagulation profile, blood type and cross-match, basic metabolic panel, liver function tests, especially in cases of suspected variceal bleeding. 5. Risk stratification. Tools like the Glasgow-Blatchford score for UGIB or clinical judgment based on signs like hemodynamic stability can guide the urgency of endoscopy and level of care. Diagnostic. 1. Endoscopy, upper endoscopy, EGD, recommended within 24 hours for suspected UGIB. It can diagnose and often treat conditions like peptic ulcers, varices, or Mallory-Weiss tears. Colonoscopy, indicated for LGIB after bowel preparation, unless there is massive bleeding or severe instability. 2. Angiography, considered if endoscopy fails to locate or control bleeding. It can also be therapeutic by allowing for embolization of bleeding vessels. 3. Capsule endoscopy or push enteroscopy, useful for identifying small bowel sources if both EGD and colonoscopy are non-diagnostic. Hemostatic interventions. 1. Endoscopic therapy, injection of epinephrine, application of thermal devices, or placement of clips to control bleeding, band ligation for esophageal varices. 2. Radiologic interventions, angioembolization, performed during angiography to control bleeding without surgery. 3. Surgical intervention, considered if endoscopic and angiographic methods fail or are not feasible. Surgical approaches depend on the bleeding source and may involve resection or repair of the affected GI tract segment. Supportive care. 1. Proton pump inhibitors, PPIs, administer IV PPIs for suspected or confirmed peptic ulcers. 2. Octreotide, used in variceal bleeding alongside endoscopic therapy. 3. Reversal of anticoagulation, necessary in patients on anticoagulant therapy presenting with significant bleeding. Post-intervention care. 1. Monitoring, intensive monitoring in an ICU or high-dependency unit for unstable patients. 2. Repeat endoscopy, consider if rebleeding occurs or initially elusive sources are suspected. 3. Long-term management, address underlying causes, e.g. H. pylori eradication for ulcers, treatment of liver disease for varices. The management of GI bleeding is complex and requires a coordinated approach among emergency physicians, gastroenterologists, interventional radiologists, and surgeons to ensure rapid diagnosis, effective treatment, and prevention of complications. Ascites is the abnormal accumulation of fluid in the peritoneal cavity, commonly caused by conditions such as portal hypertension, often due to liver cirrhosis, acute liver failure, or hypoalbuminemia from disorders like nephrotic syndrome. Other contributing factors include chronic heart failure, abdominal inflammation, e.g. pancreatitis, and malignancies. Key points in ascites. Etiology, portal hypertension, most often due to cirrhosis, accounting for about 85% of cases. Hypoalbuminemia, from conditions like nephrotic syndrome or severe malnutrition. Malignancy, especially peritoneal carcinomatosis from cancers like ovarian or colorectal. Other causes, including infections like tuberculosis or pancreatitis. Pathophysiology. Fluid accumulation results primarily from increased hydrostatic pressure in the portal vein system or decreased oncotic pressure from low albumin levels. In malignancies, blockage of lymphatic channels and increased vascular permeability contribute to fluid buildup. Clinical features. Symptoms include progressive abdominal distension, early satiety, weight gain, and potentially abdominal pain. Physical signs can include shifting dullness and a positive fluid wave test, indicative of significant fluid accumulation. Diagnostics. Imaging. Abdominal ultrasound is the first choice, helpful in detecting free fluid and underlying conditions. Acidic fluid analysis. Diagnostic paracentesis is crucial to assess the nature of the fluid and check for infections like spontaneous bacterial peritonitis, SBP. SAG, serum ascites albumin gradient, helps differentiate ascites due to portal hypertension from other causes. Management. General. Treatment focuses on managing the underlying condition and controlling fluid accumulation through dietary sodium restriction and diuretics. Specific interventions. Therapeutic paracentesis for tense ascites, and advanced options like transjugular intrahepatic portosystemic shunt TIPS or liver transplantation for refractory cases. Complications. Complications can include abdominal hernias, renal dysfunction, and spontaneous bacterial peritonitis, a severe infection needing prompt antibiotic treatment. Management strategies must be tailored to the underlying cause and severity of the ascites to improve outcomes and reduce complications. Abdominal swelling and ascites are closely related but not synonymous. Here's how they differ and intersect. Abdominal swelling. Abdominal swelling can be caused by a variety of issues, ranging from benign to severe, involving different organs and systems within the abdomen. Common causes: gas and bloating, often due to dietary factors, irritable bowel syndrome, IBS, or infections. Obesity, accumulation of fat in the abdominal area. Organ enlargement, such as hepatomegaly, liver enlargement, splenomegaly, spleen enlargement, or tumors. Fluid accumulation. Ascites is a key example where fluid accumulates in the abdominal cavity. Pregnancy, natural enlargement of the abdomen. Fasciitis. Ascites specifically refers to the accumulation of fluid in the peritoneal cavity, which can cause visible abdominal swelling. Pathophysiology, portal hypertension, most commonly associated with cirrhosis, leading to increased pressure in the portal venous system and subsequent fluid leakage into the peritoneal cavity. Hypoalbuminemia, low albumin levels, due to liver disease, kidney disease, or malnutrition, reduce the plasma oncotic pressure, promoting fluid shift from the vascular space to the peritoneal cavity. Malignancy. Cancers, particularly ovarian and gastrointestinal, can cause malignant ascites by obstructing lymphatic drainage or through increased vascular permeability. Diagnosis, physical examination. Signs like shifting dullness and fluid wave test indicate the presence of significant fluid. Imaging. Ultrasound is typically the first-line imaging modality to confirm fluid presence and evaluate the abdominal organs. Paracentesis. Analysis of acidic fluid can distinguish between transudative, often due to systemic conditions like heart failure, and exudative, often due to infection or malignancy, ascites, and detect infections like spontaneous bacterial peritonitis, SBP. Management. Underlying cause. Treatment depends on addressing the root cause, e.g., managing liver cirrhosis with medications and lifestyle changes. Fluid management. Sodium restriction and diuretic medications are standard for managing fluid accumulation. Paracentesis. Therapeutic removal of fluid can relieve symptoms and is necessary in cases of tense ascites or diagnostic ambiguity. Integration of concepts. In clinical practice, distinguishing between generalized abdominal swelling and ascites is crucial for management. While all ascites causes abdominal swelling, not all abdominal swelling is due to ascites. Effective treatment hinges on accurate diagnosis, involving a detailed patient history, physical examination, appropriate imaging, and, when indicated, fluid analysis. Jaundice and cholestasis are conditions related to bilirubin metabolism and bile flow, respectively, each with distinct but sometimes overlapping etiologies and clinical features. Jaundice. Jaundice, also known as icterus, is characterized by a yellowish discoloration of the skin, sclera, and mucous membranes due to elevated bilirubin levels in the blood, typically above 2 milligrams per deciliters. It can be classified based on its underlying cause. Prehepatic jaundice, caused by an increased breakdown of red blood cells leading to an accumulation of unconjugated bilirubin. Common causes include hemolytic anemia and conditions leading to increased bilirubin production. Intrahepatic jaundice results from conditions within the liver that impair bilirubin metabolism, such as viral hepatitis, alcoholic liver disease, and genetic disorders like Gilbert syndrome. It can involve conjugated or unconjugated bilirubin. Posthepatic jaundice, caused by obstruction of bile flow out of the liver, leading to a buildup of conjugated bilirubin. Conditions causing this type of jaundice include gallstones, tumors, and biliary strictures. Cholestasis. Cholestasis involves the impairment in bile production, secretion, or flow, which can be intrahepatic or extrahepatic. It often accompanies jaundice, especially in posthepatic causes, but can occur independently. Key features include pale stools and dark urine due to alterations in bile flow and bilirubin metabolism. Pruritus, a common symptom caused by the accumulation of bile salts in the skin. Hepatomegaly, often present in various forms of liver disease associated with cholestasis. Diagnosis. The diagnosis of jaundice and cholestasis involves a combination of clinical evaluation and laboratory tests. Bilirubin levels, total, direct, and indirect bilirubin measurements help differentiate the type of jaundice. Liver function tests, AST, ALT, and ALP levels help determine the nature of liver injury and cholestasis. Imaging. Ultrasound is often the first-line imaging technique to assess the liver and biliary tract. CT or MRI might be required for further assessment. Paracentesis. In cases of ascites, analysis of acidic fluid can help determine the underlying cause of liver disease. Treatment management depends on the underlying cause. General measures include hydration and avoiding hepatotoxic drugs. Specific treatment. For underlying causes such as viral hepatitis, autoimmune liver diseases, or relieving biliary obstruction via ERCP or surgery. Symptomatic treatment, such as cholestyramine for pruritus or ursodeoxycholic acid to improve bile flow in certain types of cholestasis. Understanding the specific etiology is crucial for effective treatment, which may involve addressing liver disease, clearing biliary obstruction, or managing hemolysis, depending on the primary cause of the jaundice or cholestasis. Jaundice, characterized by the yellow discoloration of the skin, sclerae, and mucous membranes, occurs when there is an accumulation of bilirubin in the blood. It's important to understand both the causes and diagnostic approaches to effectively manage and treat this condition. Causes of jaundice. Jaundice can be classified into three categories based on its underlying cause. 1. Prehepatic jaundice, increased hemoglobin breakdown, excessive destruction of red blood cells leads to increased production of unconjugated bilirubin. Etiologies. Conditions like hemolytic anemia, sickle cell disease, thalassemia, or other forms of increased red cell turnover. 2. Intrahepatic jaundice, liver cell dysfunction. Damage or disease within the liver impairs its ability to conjugate and excrete bilirubin properly. Etiologies, viral hepatitis, A, B, C, etc., alcoholic liver disease, cirrhosis, autoimmune hepatitis, and genetic disorders such as Gilbert's syndrome or Crigler-Najjar syndrome. 3. Posthepatic jaundice, obstructive jaundice, bile duct obstruction, prevents the excretion of conjugated bilirubin into the intestine, causing it to leak back into the blood. Etiologies, gallstones, choledocholithiasis, tumors of the pancreas or biliary tract, strictures, or external compression from pancreatic cysts or cancers. Diagnostics. The diagnostic approach to jaundice involves both laboratory and imaging studies to ascertain the underlying cause. 1. Laboratory tests, bilirubin tests. Total and fractionated bilirubin levels help differentiate between unconjugated and conjugated hyperbilirubinemia. Liver function tests, LFTs. Assessments of AST, ALT, alkaline phosphatase, ALP, and gamma-glutamyl transferase, GGT, help determine liver function and the pattern of liver injury, hepatocellular versus cholestatic. Complete blood count, CBC, can indicate hemolysis if there is an elevation in reticulocytes or a decrease in haptoglobin. Coagulation profile, important in assessing liver synthetic function, especially in cases of cirrhosis or severe liver disease. 2. Imaging studies. Abdominal ultrasound, first-line imaging that helps evaluate the liver, gallbladder, bile ducts, and pancreas. It can detect dilated bile ducts or masses causing obstruction. CT scan MRI, used for more detailed imaging when ultrasound is inconclusive or when more detailed anatomy of the liver and pancreas is required. Endoscopic retrograde cholangiopancreatography, ERCP, used both diagnostically and therapeutically in cases of suspected bile duct obstruction. 3. Additional tests. Hemolysis workup includes direct antiglobulin test, Coombs test, LDH, and haptoglobin levels. Genetic testing for hereditary conditions like Gilbert's syndrome or other metabolic liver diseases. Liver biopsy, considered when the diagnosis is unclear or to assess the extent of liver disease. Summary. The management of jaundice depends heavily on a thorough diagnostic workup to pinpoint the exact cause. Whether the jaundice is due to increased production of bilirubin, impaired liver function, or obstruction of bile flow, targeted treatment can only be initiated once a precise diagnosis is made. Lymphadenopathy refers to the enlargement of lymph nodes, a common condition that can result from a variety of factors ranging from benign infections to serious malignancies. Causes of lymphadenopathy. 1. Infections, bacterial. Common causes include tuberculosis, syphilis, staphylococcal or streptococcal infections, Lyme disease, and cat scratch disease. Viral includes HIV, Epstein-Barr virus, EBV, cytomegalovirus, CMV, and others like herpes zoster and rubella. Fungal and parasitic Examples include aspergillosis, cryptococcosis, schistosomiasis, and lymphatic filariasis. 2. Malignancies involves primary cancers such as lymphomas and leukemias or metastases from cancers elsewhere in the body. 3. Autoimmune diseases. Conditions like systemic lupus erythematosus, rheumatoid arthritis, and Sjogren's syndrome can cause lymphadenopathy due to chronic inflammation. 4. Medication-induced. Certain drugs like allopurinol, some antibiotics, and antihypertensives can induce lymphadenopathy. 5. Other causes includes diseases like Kawasaki disease, sarcoidosis, and Castleman disease. Diagnostic approach to lymphadenopathy. 1. Medical history and physical examination. Important to assess the duration, pain associated with the lymph nodes, systemic symptoms like fever or weight loss, medication history, and potential exposure to infectious agents. 2. Laboratory tests. Blood tests, including complete blood count, CBC, liver function tests, and specific tests for infections like HIV or EBV. Inflammatory markers such as C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, can be helpful. 3. Imaging. Ultrasound is commonly used to assess the characteristics of lymph nodes and can differentiate between benign, soft with a fatty hilum, and malignant, hard, rounded, loss of fatty hilum, lymph nodes. CT or MRI may be required for a more detailed assessment, especially to explore areas that are difficult to evaluate with ultrasound. 4. Biopsy. A lymph node biopsy is essential for definitive diagnosis, especially if malignancy is suspected. It helps in obtaining a tissue diagnosis which can guide treatment. 5. Special tests. Depending on suspected causes, additional tests such as autoimmune panels, acid-fast bacilli smear for tuberculosis, or serological tests for specific infections might be necessary. The management of lymphadenopathy hinges on identifying and treating the underlying cause. This may range from antibiotics for infections to chemotherapy for malignancies, or managing specific autoimmune disorders. Regular follow-up is important, especially if the lymphadenopathy is persistent or of unclear etiology, to monitor for potential progression to more serious conditions. The differential diagnosis for lymph node enlargement or lymphadenopathy is broad and varies based on factors such as the node's location, the pattern of enlargement, and associated clinical symptoms. Here's an overview of potential causes grouped by their typical presentation. Localized lymphadenopathy. 1. Infectious causes: bacterial, staphylococcus or streptococcus infections, cat scratch disease, tularemia, syphilis. Viral: Epstein-Barr virus, mononucleosis, cytomegalovirus, HIV, herpes simplex virus. Fungal: histoplasmosis, coccidioidomycosis. Parasitic: toxoplasmosis. 2. Malignancies: primary malignancies such as lymphoma or leukemia. Metastatic cancer from breast, lung, melanoma, or other cancers depending on the node location, e.g. axillary nodes commonly involved in breast cancer. 3. Immunologic autoimmune disorders, rheumatoid arthritis, lupus erythematosus. 4. Other causes, sarcoidosis, Kawasaki disease. Generalized lymphadenopathy. 1. Infectious causes: viral, HIV, Epstein-Barr virus, cytomegalovirus. Bacterial: syphilis, sepsis. Fungal: disseminated fungal infections. Parasitic: malaria, leishmaniasis. 2. Malignancies: lymphomas, leukemias, metastatic cancers. 3. Immunologic autoimmune disorders: systemic lupus erythematosus, rheumatoid arthritis, serum sickness. Other causes: chronic inflammatory states, amyloidosis. Specific regions: cervical lymphadenopathy, often caused by upper respiratory infections, dental infections, mononucleosis, or head and neck cancers. Axillary lymphadenopathy, typically associated with infections or injuries to the arm or hand, breast cancer, or lymphomas. Inguinal lymphadenopathy, often related to infections in the legs, feet, or genitals, including sexually transmitted infections. Special considerations, pediatric considerations. In children, lymphadenopathy is often benign and self-limiting, frequently associated with viral upper respiratory infections. However, persistent or atypical presentations should prompt evaluation for more serious conditions like leukemia or lymphoma. Age considerations. In elderly patients, malignancy is a more common cause of lymphadenopathy than in younger individuals. Diagnostic approach. A thorough history and physical examination are crucial for guiding further diagnostic steps. The presence of systemic symptoms, fever, night sweats, weight loss, known as B symptoms in lymphoma, the texture and mobility of the nodes. Hard, fixed nodes are more suggestive of malignancy, and exposure history, travel, animal contact, sexual history, help narrow the differential diagnosis. Additional tests may include laboratory tests, complete blood count, inflammatory markers, specific serologies. Imaging, ultrasound, CT scan, or MRI to assess the structure and spread. Biopsy, essential for definitive diagnosis, especially if malignancy is suspected. Management is directed by the underlying cause determined through diagnostic evaluation. Regular monitoring and follow-up are recommended to assess the response to treatment and progression of the disease. Lymphadenopathy, the enlargement of lymph nodes, varies in cause based on numerous factors, including the location of the enlarged nodes, whether the enlargement is localized or generalized, and associated clinical features. Here's a concise breakdown of the differential diagnosis for lymphadenopathy. Enlargety, localized lymphadenopathy. Infectious causes. Common bacterial causes include Staphylococcus or Streptococcus infections, cat scratch disease, and syphilis. Viral infections may involve Epstein-Barr virus, mononucleosis, or HIV. Fungal infections such as histoplasmosis and parasitic infections like toxoplasmosis can also cause localized lymph node enlargement. Malignancies includes primary malignancies like lymphoma or leukemia, or metastasis from cancers such as breast or lung cancer. Autoimmune disorders, conditions like rheumatoid arthritis or lupus can cause lymph node enlargement. Other, conditions like sarcoidosis and Kawasaki disease. Generalized lymphadenopathy, infectious causes, viral infections like HIV, Epstein-Barr virus, or systemic bacterial infections such as sepsis or syphilis. Malignancies, such as widespread lymphomas or leukemias. Immunologic autoimmune disorders, including systemic lupus erythematosus and serum sickness. Other chronic inflammatory states or amyloidosis. Specific considerations. Cervical lymphadenopathy often results from upper respiratory infections, dental infections, or head and neck cancers. Axillary lymphadenopathy, typically related to breast cancer, infections, or injuries of the arm. Inguinal lymphadenopathy, commonly linked to infections in the lower extremities or sexually transmitted infections. Diagnostic approach. A detailed medical history and physical examination are crucial. This includes assessing the texture, mobility, and pain associated with the lymph nodes. Painful, tender nodes are more likely to be inflammatory or infectious in origin, whereas painless, firm, and fixed nodes suggest malignancy. Further diagnostic steps might include laboratory tests, such as complete blood count CBC and specific serologies depending on the suspected cause. Imaging, ultrasound or CT scans can help assess the structure and extent of lymph node involvement. Biopsy, essential for a definitive diagnosis, particularly if malignancy is suspected. Treatment of lymphadenopathy aims at addressing the underlying cause, which may vary from antibiotics for infections to chemotherapy for cancers, or simply monitoring in cases of benign reactive lymphadenopathy. Anemia is a common hematological condition characterized by a reduction in red blood cell count or hemoglobin levels, leading to decreased oxygen carrying capacity of the blood. The diagnostic approach to anemia involves several key steps to determine its type, cause, and appropriate management. Initial assessment. 1. Complete blood count, CBC. The initial test to confirm anemia and provide crucial information about hemoglobin levels, hematocrit, and red blood cell indices such as mean corpuscular volume, MCV, which helps in classifying the anemia as microcytic, normocytic, or macrocytic. Microcytic anemia, MCV 80 Felschreiss, commonly due to iron deficiency, thalassemia, anemia of chronic disease, lead poisoning, or sideroblastic anemia. Normocytic anemia, MCV 80 to 100 FLS, causes include acute blood loss, anemia of chronic disease, aplastic anemia, or early iron deficiency. Macrocytic anemia, MCV 100 FLS, usually due to vitamin B12 or folate deficiencies, liver disease, alcohol use, or hypothyroidism. 2. History and physical examination. Assess symptoms like fatigue, pallor, and jaundice, and inquire about dietary habits, family history, medications, and any recent illnesses or chronic conditions. This can guide the etiology and selection of further tests. Additional diagnostic testing. 3. Reticulocyte count helps assess the bone marrow's response to anemia. A high reticulocyte count indicates a regenerative response to anemia, e.g., hemolysis or blood loss, while a low count suggests a lack of red blood cell production. 4. Iron studies include serum iron, ferritin, total iron binding capacity, TIBC, and transferrin saturation. These tests help differentiate between iron deficiency anemia and anemia of chronic disease. 5. Peripheral blood smear provides insights into RBC morphology that can indicate specific types of anemia, e.g., sickle cells, schistocytes, spherocytes. Specialized tests. 6. Bone marrow biopsy, considered when bone marrow pathology is suspected, e.g., aplastic anemia, myelodysplastic syndromes. 7. Vitamin B12 and folate levels, essential for diagnosing megaloblastic anemias. 8. Hemoglobin electrophoresis, used to identify hemoglobinopathies such as sickle cell disease or thalassemia. Number 9. Direct antiglobulin test, Coombs test, determines if anemia is caused by autoimmune destruction of RBCs. Imaging and other tests. 10. Imaging studies, such as ultrasound or CT scans, might be necessary if splenomegaly or other organ involvement is suspected. 11. Stool occult blood test, checks for hidden blood in the stools, which can indicate gastrointestinal bleeding as a cause of iron deficiency anemia. Integrating the findings. After obtaining the results from these tests, integrate the findings to narrow down the cause of anemia. For instance, low ferritin and high TIBC suggest iron deficiency anemia. Normal to high ferritin with low TIBC could indicate anemia of chronic disease. low vitamin B12 or folate levels with megaloblastic changes on a peripheral blood smear confirm the diagnosis of megaloblastic anemia. The treatment plan should address the underlying cause of the anemia and may involve dietary supplements, iron, B12, folate, specific therapies for underlying conditions, e.g., antibiotics for infection, chemotherapy for cancer, or supportive treatments like blood transfusions if the anemia is severe. Regular monitoring and follow-up are crucial to evaluate the effectiveness of treatment and to adjust it as needed. Multiple myeloma MM is a type of cancer that arises from malignant plasma cells in the bone marrow. These cells proliferate uncontrollably, leading to various systemic manifestations and complications due to the overproduction of monoclonal M proteins and free light chains, often resulting in kidney damage and bone lesions. Overview: Epidemiology. More common in males with a peak incidence between 50 to 70 years. Characterized by bone marrow infiltration by malignant plasma cells, which suppresses normal hematopoiesis and secretes pro-osteoclastogenic factors, causing osteolytic lesions and hypercalcemia. Clinical features: often presents with nonspecific symptoms like fever, night sweats, weight loss, bone pain, and symptoms of hypercalcemia. Renal complications such as myeloma, cast nephropathy are common. Diagnostics: initial tests include complete blood count, CBC, comprehensive metabolic panel, CMP, and urinalysis. Myeloma biomarkers: serum and urine protein electrophoresis, free light chain assay, and LDH levels are critical. Imaging: whole body low dose CT scan is utilized for detecting bone lesions. Definitive diagnosis made through bone marrow biopsy showing more than 10% clonal plasma cells or biopsy-proven plasmacytoma. Classification: types of MM based on the type of immunoglobulin produced, with IgG and IgA being the most common. Bence-Jones myeloma involves the production of free light chains excreted in the urine. Management: treatment involves high-dose chemotherapy followed by autologous stem cell transplantation for eligible patients. Those ineligible for transplantation receive chemotherapy alone. Complications management includes addressing bone disease with bisphosphonates or denosumab and managing renal disease with adequate hydration and specific therapies. Prognosis: staging utilizes the Revised International Staging System, RISS, which takes into account factors like beta-2 microglobulin levels, albumin levels, and genetic abnormalities. Outcomes: while treatment advances have improved outcomes significantly, multiple myeloma is generally considered treatable but incurable with frequent relapses. The approach to managing multiple myeloma is complex, requiring a multidisciplinary team to address the various manifestations of the disease and its complications effectively. A bone marrow biopsy is a critical diagnostic tool used in hematology to assess the marrow's structure, function, and cellularity. Here are the key indications for conducting a bone marrow biopsy. Diagnostic evaluation, suspected hematologic malignancies, essential for diagnosing various blood cancers, including leukemia, lymphomas, multiple myeloma, and myelodysplastic syndromes. Unexplained anemias, particularly when associated with abnormal blood cell counts, e.g., pancytopenia, or when specific anemias like aplastic anemia or sideroblastic anemia are suspected. Evaluation of febrile neutropenia, especially in cases where bone marrow suppression or infiltration is suspected. Staging and prognosis. Staging of known malignancies determines the extent of bone marrow involvement in diseases like lymphoma and leukemia. Prognostic information provides critical information about genetic mutations, cell morphology, and fibrosis that can guide treatment decisions and prognosis. Monitoring and follow-up. Response to treatment assesses the effectiveness of chemotherapy or other treatments in hematologic malignancies. Post-transplant evaluation monitors engraftment status after bone marrow or stem cell transplantation. Research in special cases. Infectious diseases identifies marrow involvement in infections, e.g., tuberculosis, fungal infections when blood cultures are negative. Storage and metabolic diseases diagnoses conditions like Gaucher's disease or amyloidosis where abnormal material accumulates in the bone marrow. Miscellaneous, unexplained splenomegaly or hepatosplenomegaly when blood disorders are considered as a potential cause. Unexplained elevated blood cell counts, such as in cases of suspected myeloproliferative neoplasms, e.g., polycythemia vera, essential thrombocythemia. A bone marrow biopsy provides comprehensive information that helps in diagnosing and managing a wide range of hematologic conditions, making it an indispensable procedure in many clinical scenarios. The diagnostic evaluation of the kidney and urinary tract involves a series of assessments to identify and characterize various renal and urological conditions. Here's a summary based on the key diagnostic tools and methods. History and physical examination. Symptoms assessment. Focus on changes in urine and micturition, such as dysuria, anuria, or changes in urine volume and appearance. Physical signs. Look for flank pain, costovertebral angle tenderness, hypertension, and peripheral edema, which may suggest renal disease. Urinalysis, gross examination, assesses urine color, clarity, and any noticeable odors. Dipstick test, quick assessment for pH, protein, glucose, ketones, heme, leukocyte esterase, nitrite, and urobilinogen. Microscopic analysis examines urine sediment for cells, casts, crystals, and microorganisms. Laboratory tests. Renal function tests measure serum creatinine, blood urea nitrogen, BN, and estimate the glomerular filtration rate, GFR, using formulas such as Cockcroft-Gault or MDRD. Electrolytes and other solutes, important for assessing overall renal function and identifying any related metabolic disturbances. Specialized tests includes urinary electrolytes, urine osmolality, and tests for specific conditions like myoglobinuria or hemoglobinuria. Imaging. Ultrasound, first-line imaging tool for evaluating renal morphology and detecting abnormalities such as stones, cysts, or obstructions. CT scan and MRI provide detailed images of the urinary tract and are especially useful for complex cases or where detailed anatomy is necessary. X-rays, used less frequently, can help identify kidney stones and some structural abnormalities. Additional diagnostic procedures. Urine culture identifies urinary tract infections based on the presence of pathogens. Renal biopsy, indicated for diagnosing unclear cases of renal dysfunction, especially when glomerular disease is suspected. Advanced functional tests. Inulin and creatinine clearance provide precise measurements of GFR. Fractional excretion of sodium, FeNA, helps distinguish between pre-renal and intrinsic renal causes of kidney injury. The approach to diagnosing kidney and urinary tract issues is comprehensive, integrating clinical findings with a variety of diagnostic tests to effectively identify and manage renal disorders. Polyuria, defined as excessive urine output, typically more than 3 liters per day in adults, can be caused by a variety of conditions. Here's a summary of the differential diagnosis for polyuria. Pattern 1, diabetes mellitus. Type 1 and type 2 diabetes. High blood glucose levels lead to glucose spillover into the urine, which osmotically draws water into the urine, increasing urine volume. Heart 2, diabetes insipidus. Central DI, caused by a deficiency of antidiuretic hormone, ADH, due to hypothalamic or pituitary pathology. Nephrogenic DI, due to renal insensitivity to ADH, which can be genetic or acquired, such as from medications like lithium or conditions like hypercalcemia. NARMEGR 3, primary polydipsia, psychogenic polydipsia, excessive fluid intake due to psychiatric disorders or inappropriate thirst. Compulsive water drinking, seen in psychiatric conditions which leading to low serum sodium levels and large urine volumes. 4. Hypercalcemia causes malignancy, hyperparathyroidism, and other conditions causing elevated calcium levels, which can lead to nephrogenic DI by impairing kidneys' response to ADH. 5. Hypokalemia causes diuretic use, gastrointestinal losses, or endocrine disorders. Low potassium levels can impair the kidney's ability to concentrate urine. 6. Chronic kidney disease. Early symptom: as kidney function declines, the ability to concentrate urine diminishes, leading to increased urine output. 7. Medications. Diuretics intended to increase urine output can cause or exacerbate polyuria. Lithium can lead to nephrogenic DI. Other medications, such as antipsychotics, can cause polyuria through various mechanisms. 8. High protein or high sugar diets. Osmotic diuresis. Consumption of excessive protein or sugar can result in increased solute excretion, which pulls water into the urine. Diagnostic approach. To diagnose the underlying cause of polyuria, a comprehensive approach including the following tests may be utilized. Urine-specific gravity and osmolality, to assess the concentrating ability of the kidneys. Blood glucose levels, to rule out diabetes mellitus. Serum electrolytes, including calcium and potassium, to check for hypercalcemia and hypokalemia. Water deprivation test, to differentiate between types of diabetes insipidus and primary polydipsia. ADH vasopressin challenge test. For central DI, administering ADH can help determine response and differentiate from nephrogenic DI. History and physical examination, including medication review and assessment for signs of underlying conditions. Polyuria can be a symptom of a variety of diseases, and identifying the cause is crucial for appropriate management. Urinalysis is a common diagnostic tool that helps in the evaluation of various kidney and urinary tract disorders, as well as systemic diseases. It generally involves three main components: physical examination, chemical testing, dipstick, and microscopic analysis. Here's how to interpret common urinalysis results. Physical examination, color. Normal urine ranges from pale yellow to amber, depending on hydration. Unusual colors like red or brown may indicate hematuria, myoglobinuria, or substances such as medications or foods. Clarity. Urine is typically clear. Turbidity may suggest the presence of cells, bacteria, or crystals. Odor. An unusual odor can be associated with certain dietary factors, infections, or metabolic conditions. Chemical testing, dipstick. pH. Normal urine pH ranges from 4.5 to 8. A high pH may be seen in urinary tract infections or renal tubular acidosis, while a low pH may indicate conditions such as diabetic ketoacidosis or diarrhea. Specific gravity measures urine concentration with normal values between 1.005 and 1.03. Values outside this range can indicate various states of hydration or kidney disorders. Protein albumin. Normally, very little protein is present in urine. Proteinuria can be a sign of kidney damage, particularly of the glomeruli, as seen in conditions like nephrotic syndrome or hypertension. Glucose. Typically absent in urine, its presence usually points to diabetes mellitus when blood glucose levels exceed the renal threshold. Ketones. Not normally present in urine, their presence is often associated with diabetic ketoacidosis, fasting, or high-fat diets. Blood, hemoglobin, not normally present. Hematuria can indicate urinary tract infections, stones, glut, or more serious conditions like malignancies. Hemoglobinuria may occur in hemolytic anemia. Bilirubin, usually absent, presence suggests liver disease or bile duct obstruction. Urobilinogen, normal in small amounts, increased levels can indicate liver disease or excessive hemolysis. Nitrites, typically absent, presence usually indicates a bacterial infection, particularly by nitrate-reducing bacteria like E. coli. Leukocyte esterase indicates inflammation or infection if present, often correlating with urinary tract infections. Microscopic examination, red blood cells, normally few or none, presence can indicate glomerulonephritis, urinary tract infections, stones, or trauma. White blood cells, typically few, increased numbers suggest infection or inflammation. Epithelial cells, few transitional cells from the bladder are normal. Increased levels or the presence of renal tubular cells can indicate tubular damage. Casts. Hyaline casts may be seen in normal individuals. Other types like granular, red cell, or white cell casts can indicate tubular disease or glomerular damage. Crystals. The presence and type of crystals can indicate metabolic issues such as uric acid, calcium oxalate, or cystine stones. Bacteria, yeast, and parasites suggest infection or contamination. Summary. In summary, each component of the urinalysis provides critical information. Physical and chemical evaluations can quickly indicate conditions such as infections, diabetes, and kidney dysfunction. Microscopic analysis adds detail by identifying specific cellular elements and casts that pinpoint the location and nature of urinary tract and kidney disorders. Interpretation of urinalysis results should always consider clinical context, as many findings can be influenced by factors such as diet, medication, and hydration status.